Okay, I think we're good to go. So good morning, everybody. Welcome to our board meeting in public. And it's today's 28th of September, so it's coming into the autumn. Just to remind everybody that the meeting is being recorded and we're going to be making it available for public viewing on our website, so we just need to be mindful of that. I just wanted to also take the opportunity to welcome governors who may be observing us today and any members of the public who've opted to do so as well. I wanted to acknowledge that I think Paul Sheldon, who actually I can't see on screen, it's he's here. There we are. There I can see Paul now. Sorry, Paul. It's a big screen with lots of people. Just wanted to acknowledge that Paul is now here, not only in his capacity as Chief Finance Officer, but with the additional accountability around finance. And also, I believe, Richard, this is your first board meeting formally, as Director of Corporate Governance. So just wanted to acknowledge that, and congratulations again to you, Richard.
Thanks very much.
Okay, so we'll just mention as item 2, apologies for absence for this meeting. So we have apologies from Dave Mayer, our Deputy Chief Executive and Managing Director, and also from Joanne Lancaster and Tim Harrison. I received apologies from Tim personally. Personal circumstances have arisen where he's had to miss the meeting. And I know Anne needs to leave at 11 due to an important meeting that we'd already agreed she needed to attend. So I will make sure we'll cover what we need to, hopefully, Anne, whilst beforehand. So I think that's all the apologies, and we can move then to declarations of interest. Are there any items of declarations of interest for items on the agenda today over and above the register that we have available? Okay, I'll take that as a none. So moving on then to minutes of the previous meeting. That's our meeting held on the 27th of July, which is paper A. Can I check with colleagues if we're comfortable that it's actually an accurate representation of our meeting? So I don't hear anything otherwise. So, or Linda, would you like to come in?
Good morning, Krishna. Thank you. I just wanted to highlight on page 11 of the board minutes where there was mention of pressure ulcers. I just wanted to clarify that in the last meeting, what I meant was that when a pressure ulcer is initially graded as ungradable, even though that pressure ulcer is healing and will have healed, we do not regrade it. However, if a pressure ulcer is graded as a grade 1, grade 2, and subsequently deteriorates further, it would be reassessed and would then be regraded. So it would be graded going upwards. So I just wanted to make that clarification if I hadn't articulated it as clearly at the previous meeting. Thank you.
Thank you, Linda. Are we all right to capture that, Jane or Richard? Do we want to are we clear about what we're capturing and changing? Yeah. I think Linda's explanation was very clear there. So we just need to make sure the minutes accurately reflect that. So Linda, in the interest of time, we won't try and review the exact wording at the moment, but we'll make sure we've reviewed it retrospectively and made that change if everyone is comfortable that we do that. Thank you very much. Julie.
Sorry, I've clicked my hand up by accident. Sorry, I thought I'd take you down again. Sorry, Krishna.
Okay. Thank you, Julie. It's possibly a delay. Sometimes I think there are some delays in the way hands go up and down, so no problem at all. Right, so we'll note that, and subject to that amendment, Linda, then we'll approve the minutes as they are, but make that change and note that change subsequently in today's minutes. Are there any matters arising apart from those items on the action sheet? No. Okay, so we'll move straight onto the action sheet, which is paper B. And just checking then on the first item on that list, FT 2379. This was, I think based on the patient staff story we had, we thought there was a really good case study potentially for to illustrate career progression. And I don't know whether that's been able to be taken forward. So, Chris, obviously, I think you were...
Yeah, it has, Krishni. The
Okay.
HR team, they're liaising with, I don't think they've completed it all yet. They're liaising with Paul Fletno, who's the lead for psychology, our director responsible for psychology. And they're drawing that together and going to feed it into opportunities to publicise it for career development and recruitment.
Okay, so is the board happy to close that off? Okay, thank you. Then I think the next action was completed anyway. And also we have a plan, FT 2396. We have a plan to invite the new director for the charity to the board meeting. You did one thing I just wanted to clarify. What was the timescale for the governance review? Was that going to happen as part of the process or not? Or can we ask the new director that question when he comes?
I think it would be best if we ask Jonathan that when he comes. I know that Jonathan is, in fact, already putting some changes to the governance in place, but whether there'll be a governance review is at the moment unclear. Okay,
so that invitation, I think, is the key then, isn't it? To bring him along, and then we can, the board can engage with him. David, thank you. David, did you want to come in?
It was just to make everybody aware that the charity has got a joint appointment with NHFT to look at how we can support some of the charity strategy work and the ways of working forward. That individual started, and so we're looking at them coming to the executive meeting at the beginning of October and then into the board workshop that follows slightly in October. So we'll be able to spend some more time talking about charity strategy, how that links with NHFT. And then that will feed into, I think, a richer conversation that Judith just talked to as the Chief Exec Managing Director comes through and feeds into that.
Okay, thank you. Judith?
Very briefly, Krishni, David, thank you very much for clarifying that, because it was in fact at the North West Hants Governors meeting only earlier this week that the third sector strategy was raised and discussed by governors. So that will be a really timely meeting to have, both at the board workshop and at the board. Thank you.
So just actually picking up the point about the board workshop, I suspect that's too soon though, isn't it? Because our board workshop is next week. So the next one will probably be earlier in the new year, I think, Richard. So we might just need to look at timing on that, but it's probably going to need to follow into the new year. Does that still work, David? I think that's probably more timely in some ways, isn't it?
Yes, I think it does. The member of staff new into post, so they've got a goal and a vision that they're working on, but not the detail at the moment. So they'll have that for January.
Yeah, and we'll have had the conversation with Jonathan as well in the meantime. So good. Okay, so we'll keep the annual update is due to be scheduled. So obviously we'll or it is completed actually. It's scheduled on the board forward plan, but obviously we need to secure the invitation, which will be important for us to follow up on. The integrated organisational report, the board had a discussion at its last meeting about bringing that forward because we were pleased with the progress on the report. So it is actually follows the risk item on the agenda, and I believe that's the case. the strategy item on the agenda. So we should get to it fairly early, hopefully in the piece today. And we can take stock and review that. I mean, the board agenda is fluid in that sense, but I think because it was now such an integrated document covering a whole range of different elements from sort of operational performance to finance to people and quality, we felt it was, I think the board felt it was useful to have it earlier in the agenda. So it's moved for now, but we can take stock depending on how colleagues feel that's the positioning is appropriate. And then the final item on their board development programme, I think we can close off. Obviously, the board development programme is in itself a fluid work plan, and colleagues are welcome to suggest items for inclusion at any time. But we do have a sort of thematic forward plan that we have in place at the moment. I don't think there's anything from paper C that I want to highlight, which is the annual forward plan. So if there are no further comments or questions, I think we can move to our patient story. And I'm really delighted today that it's focusing on our learning disability service. And I think you're going to introduce it for us.
Yes, thank you, Krishni. I'll keep the introduction short because I think it's really important to hear from the services. But myself and Scott went on a service visit to learning disabilities recently, and we had a really good visit, learning about so many different aspects of the work they do. We thought it was important to bring it here because the work that they do and the outcomes for people really fit our vision and values as a trust. So I'm going to hand over to Kirsty Clark, our service manager, and Elizabeth, specialist physiotherapist, to lead us through. Thank you.
Good morning. Thank you, Anne, and thank you for inviting us. We are very excited to present to you all this morning. I'll share my power. We've done a little PowerPoint for you all, so we'll share this with you. Hopefully it'll work.
Can everyone see?
Can everyone see that?
Yeah, that's there. Thank you.
Perfect. Thank you. Okay, so I'm obviously Kirsty Clark. I'm the interim service manager for the community team for people with learning disability, the children's community team for people with learning disability, and also Willow Close Respite Unit.
And I'm Liz Wilson. I'm the lead physiotherapist in the South for CTPLD.
So hang on, sorry, we'll have a technical issue now of moving the PowerPoint on.
Let's try that.
That is it. Oh, there we go. Sorry. So the community team for people with learning disability, we're a specialist team within NHFT who support children and adults with a diagnosed learning disability, and we support them in many different ways. The teams are comprised of speech and language therapy, physiotherapy, occupational therapy, nursing, psychology, psychiatry, and recently a pharmacist, which has been really, really great addition to our service. So the primary focus of CTPLD is to support the health inequalities that people with a learning disability experience. Learn from our learning disability mortality review programme, the reviews that we receive from those, and also to affect that change. So health inequalities for people with a learning disability. I'll just give you a little bit of background to the patient story, really. So people with a learning disability are still dying earlier than the general population. So they die 23 years earlier for men and 27 years earlier for women. And as an addition to that, for ethnic minorities, it's higher. The numbers are higher than that. Half of the deaths are potentially preventable. People with a learning disability have significantly more health conditions, and they're 16 times more likely to be prescribed antipsychotic medications that bring them with them the potential serious side effects and premature death that we see in our leader reviews. So the leader review is a service improvement programme for people with a learning disability and autistic people. It was established in 2017 and funded by NHS England. And the leader, it works to improve care, reduce health inequalities, and prevent people with a learning disability and autistic people from early deaths. So it's a real focus of our work that we do in the team. So some of the common causes that come from the leader outcomes are things such as dysphagia and aspiration pneumonia, diabetes, constipation, cancer, and epilepsy. And these are the things that we are focusing on. So the findings, we're going to talk about constipation today because it still astounds everybody when you talk about people dying from constipation in 2023. And so people with a learning disability are at a greater risk of constipation. 10% of the general population will experience it, but 20 to 50% of people with a learning disability are affected by constipation. They're at higher risk of constipation due to side effects of medication, poor diet and hydration, abnormal muscle tone or spasticity, lack of toileting opportunities, believe it or not, lower expectations of carers and professionals surrounding toileting, poor mobility, reduced range of activities, toilets not meeting the need of the service users, again, quite astounding in 2023, and difficulty to communicate their needs to others. So constipation is one of the 10 most frequently reported long-term health conditions among people with a learning disability who died in 2020. And over a third of those deaths that were reviewed in 2020 from the annual report of the leader findings were prescribed laxatives. And appropriate use of laxatives can help, but it can't substitute for a healthy diet, adequate hydration, and regular appropriate physical exercise. So I'm going to hand you over to Liz now, who will talk about how we target constipation within the community.
Thanks, Kirsty. So we have an abdominal massage pathway that we've instigated within CTPLD. It's one of the first in the country that was established quite some time ago. And quite a lot of other services will come to us to ask how we run our service and use that for their basis for their service as well, which is quite proud of that. So abdominal massage is a manual technique that's applied to the ascending, transverse and the descending colon to physically break down and move blockages caused by constipation. It's natural and non-invasive, and it's generally a pleasant, relaxing experience that our service users tend to enjoy. And it is believed to increase peristalsis in the gut and reduce colonic transit time, so basically the amount of time it takes from eating to going to the toilet. So Mr. H is our chosen patient for our patient story today. He's 39, he's very sociable and he's often at his local social club or out for meals with his family. He loves all music, he's a huge Liverpool Football Club fan and he enjoys having a flutter on a scratch card, horror movies and WWE wrestling matches. He's also got a diagnosis of cerebral palsy, Pelizaeus-Merzbacher disease, which is a neurodegenerative condition. He has epilepsy, a moderate learning disability and a wheelchair for all his mobility, and he's hoisted for all his transfers. So he presented to our team with chronic constipation, which was being managed at the time by district nurses visiting him 3 times a week to deliver suppositories, which you can imagine was invasive for him and time consuming for the team. He was taking daily laxatives to help manage his bowel movements. He had a distended, tender abdomen, and his mental well-being was affected due to physical symptoms, as you can imagine. I don't know if any of you have ever experienced it. Even a bit of trap wind can be very unpleasant. But also he was missing out on social opportunities, which for him were a big part of his life, because often the district nurses were unable to get to him until 9 p.m. at night, but he wasn't aware of, they sort of gave him a bracket of time in which they were coming. So he wasn't able to sort of plan his day around what he would like to be doing as well. So it was having a big impact on his life. So he was referred to our service to assess for suitability for abdominal massage following our specific abdominal massage pathway. We asked carers to complete bowel charts for 2 weeks and diet and fluid charts for 2 weeks to see if there were any tweaks that we could make to his lifestyle and his routine that might affect his bowel movements as well. He was deemed appropriate for abdominal massage. We got consent from him, and also we asked GPs to give consent to say that there are no precautions or contraindications that they're aware of that we need to take into consideration as well. So we then proceeded to deliver the abdominal massage on Mr. H to check he tolerated it, because sometimes some of our service users aren't very receptive to tactile intervention. He tolerated it well, so we trained the carers up, which consisted of 1 theory session and then 2 practical sessions. And then we maintained the delivery of the abdominal massage 2 to 3 times a week while the carers were being trained as well. But then once the carers was completely signed off, the abdominal massage was delivered by the carers, and CTPLD didn't need to provide that input anymore. So we stopped providing abdominal massage because the carers were completing that then. So subsequently, Mr. H was having regular bowel movements 2 to 3 times a week. The district nurse's visits were reduced here 2 times a week, then 1 time a week, and then completely stopped. So he wasn't needing to take any suppositories. The carers were managing the constipation via the abdominal massage. As I said, there weren't any need for suppositories, which was really good for Mr. H. He had reduced oral laxatives, reduced abdominal distension and pain, and generally a better quality of life. So following the abdominal massage pathway meant that Mr. H had improved quality of life, less medication was needed by the patient. Carers could independently manage a chronic problem which had potential to hospitalise and at worst cause death, and district nurse hours were saved as well. So that really is our summary of Mr. H. Has anybody got any questions?
Thank you so much, Kirsty. And you like to be called Liz?
Yes, please.
Yeah, great. Thank you both so much. Really, really insightful. And I'm sure there will be, you can see the hands going up, both of you. So I think there will be questions and comments, I'm sure, about the insight you've given to your team and the service you provide, and indeed the Mr. H and the particular story relating to him. So I'll bring in everybody in turn, Kirsty and Liz, and then we'll see how we're doing. So Saqib first.
Thank you. That was really insightful, and it's concerning you mentioned about the ethnic minorities having an earlier mortality. So I just wanted to understand if there's any indication what might be causing that. In my university days, I actually worked at Brom Hospital. Unfortunately, it used to be hospital settings back in the 80s and early 90s. They had come in as children in their, between I think 7 and 15. When I was working with them, they were I think between 25 and 35 with learning disabilities. But I'd love to hear if you have any insight as to what causes the difference for ethnic minorities. Thank you.
I think a lot of it is access to service, and also different cultural expectations of how families manage people with a learning disability within their own culture. We are doing a piece of work around the ethnic minorities and things that we can do to look at and how we can support better and provide earlier intervention, because I think sometimes it's about that early intervention and how we get the support known out there of what's available. So yeah, we are doing a piece of work around that at the moment. And I remember Bromham Hospital, so days gone by.
Thank you, Kirsty. So there's something there about sort of trying to reach the communities and make sure there's a piece around education and understanding of what support is available and can be provided, which sounds really important and valuable. Sadly, I have heard that data relatively recently. It was highlighted regionally, actually, as something we should all be really concerned about, the disparity that already exists for people with learning disabilities, and then you add on sort of other protected characteristics, and that just compounds it really, which is very concerning. Julia.
Thanks, Krishni. Hi, Kirsty and Liz. I'm Julia Curtis, one of the non-exec directors. A comment and then a quick question, if that's okay. Comment is that was incredible, really incredible. And I can just imagine the impact for people. As you say, it's astounding, isn't it? That something that appears so simple is just affects people's lives so greatly. But huge congratulations for the effort I'm sure that's taken to get that off the ground for the pathway for a start. But I don't underestimate the improvements to people's lives that you're making through that. So thank you for that. The question is, I suppose, for the wider population, for people who don't have learning disabilities, we have an awful lot of frail older people who suffer from similar conditions, and I just wondered if the learning is shared elsewhere, or if you had the opportunity to share that to other services here and you know, regionally, nationally, etc., to help people get that off the ground. So thank you.
Thank you. We've recently done some work actually with the children's continence team, and we're very aware of making sure that within NHFT the service we provide is equitable. So we're having a sort of focal hub of resources and training that we all access and we all attend to maintain our competence within the trust. So it's not exclusive to learning disabilities. I don't know that there is anybody that's particularly engaged around elderly care, but that would be interesting. If you've got any contacts, we'd be more than happy to branch that out. I think, yeah, it might just be a bit more in terms of delivery of the service. If it's a technique that's applied by carers, it can be self-taught though, so it would be something that could potentially be self-taught to elderly population, that we could, but yeah, be happy to be contacted by other services within NHFT to share our knowledge.
And in terms of nationally, I believe that one of the physios who has now retired set up the network for abdominal massage. So that's how it's been rolled out nationally, and that's how people come to us as a service to ask us how we managed to get it up and running and to actually roll it out. So we've done quite well with that.
Thank you very much, Kirsty. And I think your messages about how you've trained carers, I think that's a really important point about sustainability, isn't it? And I think in a sense that how we help people to self-care, or carers to support people in the communities, probably needs to be just a sort of almost something we think of all the time, because it's how we make some of our services sustainable. So I think there's a really good lesson in that. David.
Lovely, thanks, Krishni. Kirsty, Liz, thank you very much for the presentation. I completely agree with Krishni. I think you've given us a brilliant example of partnership working, but also about the fact that we're helping people live what is for them their normal life by having their carers able to look after them and support them and not needing lots of NHS visits. And I think that's incredibly powerful, because actually the more visits you get, the more it disrupts your routine. And you gave some really good examples of how it changes people's social patterns. So I think it's good. I also wanted to say thank you very, very much for bringing the conversation of constipation into a public board meeting, because you've handled it incredibly sensitively. It is something that we all have to talk about more. You flagged right at the very beginning the importance and the difference this makes in wellbeing. So I'm really, really pleased we've been talking about it in public board today. And I'd say please keep bringing it into public meetings. The final thing I was just going to say, Anne, it's just a reflection. I can't remember whether we brought the leader report for this year to board, but I'd be really supportive, if we haven't, of finding a time in a public board meeting where actually we note the key things from leader, because the more we talk about changing the inequalities, the more chance we've got of making a really big difference. So that would be great. Thank you.
Thank you, David. Just that point, the final point on that, the leader report, I will need to be reminded whether we have, I think we've certainly, I'm assuming that goes to patient safety, but is it something we would like as a board to receive a more detailed update on? So is it an annual report that which would be helpful for us to get further insight? Julia, I know you can't see me looking at you, but I'm vaguely looking at you because I know you've been to patient safety, or Linda or Julie might want to comment as well as to whether we can perhaps just highlight some of the learning from that, which might be helpful.
Yes, Krishni, it does come to patient safety because the Patient Safety Committee, which feeds into Quality and Safety Committee, actually summarises learning from deaths completely. We merged with the Learning from Deaths group.
Yes.
So we do see learning from the leader process, but anything that makes it much more visible and focuses our attention on this important area would be welcome. So we can look. I'm sure we could look at that with Linda. Julie, others.
Yeah, thank you. No, that's a helpful point. Thank you. Okay, Scott.
Yeah, thank you, Krishni. Hi, Kirsty. Hi, Liz. So my name's Scott Adams. I'm one of the non-executives. And if you think back to Anne's brief intro at the start, it was Anne and I who came and had the service visit with you guys and your team. So I suppose I should be thanking you, but also taking responsibility. It's my fault that you guys have got dragged here today, right? That said, I mean, your presentation was really excellent, and I think it just gave us an exemplar of what we experienced on the day. So I don't have a question. I just wanted to reflect on the experience that we had, Anne and I, which was that effortlessly we were taken around an area where it was absolutely evident that there was a very, very strong team working, and for that to stand out against the backdrop of an organisation like NHFT is a real compliment to you. We had the privilege of sort of coming across almost a bit of an extended team review that was going into the requirements of some service users, and nobody was putting that on for us. It was happening, and the level of passion and commitment and focus that was going into that was really, really commendable. I think we also were able to see some of the preparatory work that was going on for some members of the team who were just getting ready to go out and have the visits with users of the service, and the depth of that preparatory work was incredibly impressive because it was all about trying to establish rapport and stimulus for the service users, and I'm sure to them it just came across like part of their job, and to me, as someone who walked in and experienced it, it was really a shining example of incredible commitment. I suppose that the final bit I wanted to pick out, and Anne and I have had a few wry smiles about this, right, which was that on the day, sorry ladies if it was one of you guys that had this experience, but on the day the person who was supposed to meet for the service visit got held up at Northampton General Hospital. It was you, Kirsty.
It was
yeah.
me.
Yeah.
It was, sorry.
No, but I mean, obviously those things can happen, right? But what happened was the rest of the team picked it up. And the individual that took us around the service didn't know that she was going to be managing a service visit 30 minutes before it. And actually, that was, in a kind of bizarre way, Kirsty, all the more impressive, right? Because wasn't prepped to take a service visit or anything like that, just did a fantastic job in representing the service. So, genuinely, on the day, it was a hugely impressive service visit. And from my perspective, the whole reason for speaking to Anne about it on the day was that you just felt like an incredibly professional team that deserved a little bit more profile. So thank you for everything that you're doing on behalf of the organisation, and thanks for your presentation today.
Thank you.
Thank you, Scott. Oh, that's lovely. It's really great that we can connect what you and Scott, your service visit and your experience of seeing that to the patient story that we've heard, and Kirsty and Liz's presentation. So that's really fantastic. Thank you. Angela.
Yeah, thanks, Kirsty and Liz. And this is my passion, learning disabilities. So really pleased to be having you with us at the board today. And just to say that for those who have worked less with people with communication difficulties, as a former speech and language therapist, I've worked within the learning disability teams, and often these physical health symptoms can be perceived as challenging behaviour. So this is how important this work is, and I've seen that many times. So I can't stress enough the importance of the work that Liz and Kirsty have shared today. But I wondered, Kirsty, whether you could say a little bit more about the multidisciplinary team, because you put up the people, and I know that it really does make that difference in terms of how you're working in that holistic way to support people's needs. But could you say a little bit more about the MDT and why that's so important for this cohort of people, please?
Yeah, the multidisciplinary approach that we take within learning disability is paramount and fundamentally the basis of the team, really. Somebody with a learning disability, as you've said, Angela, if they're displaying behaviours that challenge. We have to look at, the management of that behaviour, but we also have to look at why that's happening. So within that, you would need a speech and language therapist to support with that. There may be some trauma attached to it. So there may be a need for support with the communication, but also with some psychological based therapy around that. There may also be some physical health reasoning behind that. So that's why, you know, the nurses and we have that link with primary care to be able to support that. And we also, you know, within any behaviour that challenges, we would have a need for a promotion of activities. It could be a sensory issue, so OT would need to be involved in that. So we really do look at that person from a holistic point of view, and I think we are one of probably the only services that do that, in terms of we really truly work in a multidisciplinary way, because we have to have elements of every profession involved in that person's care. And we are very fortunate to be able to have all of those professionals under one team. So we're not having to try and access that from other teams. It helps us to be able to put that into place for somebody very quickly, in terms of all of us coming together to work on the same issue, different issues for the same person. So we might have waiting lists, but if one of us is picking somebody up who needs a speech and language therapist involvement as well, they will come in. And so we are fortunate in the fact that we have that MDT close working within the team.
And from referral as well. If we have a new referral in, an initial assessment, which is a holistic assessment, is completed and then brought to team meeting for discussion, every single one. So even if we weren't sure that maybe speech and language might need to be involved, speech and language can pipe up and say, oh, pop us a referral over and we'll have a look as well. So it's really, it's a really good place to be.
Indeed.
Great.
Thank you, Kirsty. Thanks, Liz. Yeah.
Thank you both for bringing that to life even more. Robin.
Hi, yeah, I'm another Ned, someone who's also got experience of working with learning disabilities. Brilliant work, Liz and Kirsty, absolutely first-rate stuff, and something so simple that changes people's lives. I just wanted to add about the leader data more generally, because although it hasn't come to our board, it did actually go to the last ICB quality meeting, which I and Julie attend. So they considered it at their last meeting, and there was a very positive response to it, and general feeling that quite a lot of the data indicators were going in the right direction for leader data as a whole. I hope you feel that as well, not just for this area, but for other areas of harm, as it were. So it was a very positive message and very well received. So well done.
Thank you very much, Robin. And I think just going back to right to the beginning of what I think Kirsty was started with, you know, that actually this is all about inequalities, isn't it, really? And you know, we talk about inequalities as something kind of that maybe is sort of we're trying to do, but actually this is inherent in, you know, it's almost like we treated it in some respects when we're in the creation of the ICB and all of that as an area of focus that we're really trying to drive. But this is sort of my sense is this is already inherent in this service, and we have a number of services where addressing inequalities is a sort of core element of the service, because the population we are actually serving already experiences those significant inequalities, and everything we're trying to do is to address that. So really powerful, and clearly there are a couple of things that we've said we'd maybe just reflect on and follow up. One is just, you know, do we need to be have an opportunity just to reflect more on the leader learning that a couple of people have highlighted? Do we want to see that in a specific way, whether it's through patient safety report or other? I'll leave that to Julia, Linda, and Julie to consider. And just that point, that broader point that David made, I think, about wider learning. You know, is there learning from this service that can be shared more widely for other groups really that we're serving? And that might be something we can perhaps just ask, and not to consider as an action point per se, Anne, but maybe something you could just sort of think about in terms of sharing learning across these services. just to say thank you, Kirsty and Liz, then. Really powerful, really good to hear everything you do. I have to say that early on in my time with NHFT, I spent a day with the team and including had the privilege of visiting patients in their own home. It was probably one of the most powerful days I've ever spent in my life, actually. So I'd just say thank you, because I still remember that, and I still think what an amazing job you do. So thank you so much for joining us and telling us about it. I think it's really brought it to life. So thanks again. And thanks, Scott
Thank you for having
and
me.
Anne, for bringing us the story as well. Thanks both.
Thank you.
Bye.
Bye.
Bye. Right. Wow. Well, what a great way to start our board meeting. Okay, so I think just looking at the agenda, we're a little bit behind, but always good to spend time talking about patient story and patient experience. So what I suggest we do, just to make sure we've got Anne for all the bits we really need her for, I suggest we do the risk item as normal, and then we go straight on to integrated performance report. And then we'll take strategy after that, if that's okay with everybody. So paper D, Richard, over to you.
Thanks very much, Krishni. Good morning, everybody. I'm really pleased to share this this month's risk report. I'm, of course, always pleased to share the report, but particularly this month, because this is the first time we're talking about the development of our new board assurance framework in more detail. So I was sorry to have missed last week's workshop, but was very grateful actually that the discussion continued in my absence, and thanks to in particular for colleagues for their work in taking that forward. So what we've got in paper D is a fairly embryonic form of our new board assurance framework, in which we can see that the refined strategic priorities, which were the subject of a board workshop discussion back in August, are featured alongside then 11 new strategic risks, which speak to the delivery of those strategic priorities. As board members will note, we've got some further work to do to flesh out the full details of each of the risks, but hopefully the risk descriptions are sufficient to understand what the risk actually is, and what you can see against each of the risks that we've set out in the report, incidentally under the DIGBQ strategy headings, are where we are now in terms of a total risk score, and then where we want to be into the future, the target risk score, which will then be supported by the action plan, which is again set out in summary in the report. So in addition to sharing the latest position on the development of the strategic risks, it's also worth mentioning there's a parallel piece of work going on with colleagues within the Executive Management Board, and that's looking at how we maintain oversight of our key operational risks through our corporate risk register, and that will be something that we'll bring forward through committees over the coming months, so that board members have a holistic picture of both those risks to our strategy on the BAF and those risks to our day-to-day business on the corporate risk register, which I know was the subject of a conversation at board in previous months. So subject to the board being comfortable with where we're heading with the BAF development, what we'll do after the meeting then is to finesse the definition and underpinning evidence to support each of the risk definitions, and then regularise the reporting on those risks through committees, so that NEDs in particular can test the assurance against each of those areas. Just as an aside, really, but important to note nonetheless, in the report we've also mentioned that we've taken account of the letter that we received from NHS England, and this was on the subject of RAC. We've been looking at this for several months, perhaps even a couple of years really, but I think following the highly publicised letter from the Department of Education, we were asked to formally consider this within the organisation, and just really wanted to make the board aware that we have considered the risk to the trust, and we're satisfied that we don't have any RAC within our estate. Therefore, we don't need to take any additional action beyond those that we've got in place. So I think in the interest of time, Christian, I'll perhaps hand back to you to facilitate any discussion we may have. And as I say, just thanks again for colleagues' work on getting us to this point in the genesis of the BAF. Thanks very much.
Thank you, Richard. This is a developing, evolving risk management, I think, in action. So just wanted to check whether anyone wants to clarify anything or raise any questions. Judith?
Thank you, Krishna. Richard, thank you for presenting the paper as well. Really good to see both at the workshop, but also today, the development towards the BAF. The only question I've got, and apologies if I've overlooked something, was in relation to partnership working. The ICB doesn't appear to be mentioned anywhere. I don't know if that would be something that we'd want to cover off within that area, because it does impact on our strategy, and clearly we are working in partnership with the ICB. So I'm just throwing that out there. I don't know if we need some form of a risk around that, but that's for consideration. Thank you.
Thank you, Judith. So maybe can we just perhaps cut any points that we want to just get ask you to just have a look at and review rather than debate here. But I think that's a useful point, Judith. Thank you, Melanie.
I just wanted to reaffirm, if you like, the really positive discussion we had at the board development workshop last week. Was it last week? I lose track of time. But it was it really was a good debate, and we had a really great opportunity as a board to thoroughly explore this and comment on the priorities and the risks. And a number of comments and points were taken on board, which we will see as I said, this is a developing piece. I just wanted to specifically also draw attention to the element on the last page of the report about social value, and how eager we are to see social value equally reflected in our BAF. And I took great assurance from the fact that that piece of work is being done, is evolving. We are going to see a social value charter, and it will be reflected in the BAF as required once we've got that charter underway. So I just wanted to re-emphasize that, really. Thank you, Richard.
Thank you, Melanie. Julia?
Thanks, Chrissy. Just a quick comment around the quality and safety strategic priority. And it's really good to see the first sentence literally is about striving to improve patient outcomes. And I know at our governor meeting in the North area last week, we had a detailed conversation about our, how keen we are to provide really good services that aim at prevention of ill health. And as we've heard earlier this morning about people living, the best life they can. And actually this feeds into that completely. So our focus on patient outcomes won't be lost through this. It's really, really important, because it's there's no point in having services if we don't improve outcomes for people generally. So really good to see that, and a really good discussion at the Governor Forum to help shape that, I think. So thank you.
Great, thank you, Julia. I think just a couple of observations from me. Again, welcome all the developments and endorse the comments that people have already contributed. I did just wonder again under partnerships whether then, we need to think about whether the VCS needs to be mentioned within that. That may be picked up under that broader social value piece and a number of other things, but just wondered, question really rather than anything else, David, whether it's helpful to given there's such a key partner going forward, whether we need to think about our approach, and I'm sure we've already got work ongoing in that, so it's whether it needs to be reflected in that. So that was just a question from me. And I think the only other thing is, again, probably because I felt we're already needing to do it, and therefore is it something that ought to be in perhaps under quality, but that PCREF, I think I think we talk about risk that we do not deliver consistently high quality, equitable, co-produced services. And I wondered whether implementing PCREF might be one of the mitigations or management actions that we take to support that. So just another thought about things that I know we were doing that might want to be featured under in those areas. And then picking up, I think, what others have said, the importance of perhaps the ICB being reflected in there and social value. Does that, is everyone content that that allows us the opportunity to feed in some thoughts? I think we're supportive of the development and the approach that's being taken. So just some additional thoughts, I think, from board colleagues that we might want to reflect in there, and we'll leave Richard and David and others to work that through. Chris, do you want to make a final comment?
Yeah, I was just going to add to your point about PCREF. We had the Quality Inclusion Board yesterday, and it's reported back in there the work that's progressing with the Moving Ahead project and the PCREF, in which we are making, I think, good progress. So it's just to underpin what you're saying, Krishni.
Great, thank you, Chris. That's really helpful addition. Okay, so I think, Richard, you're just looking for us to, we've considered the refresh strategic priorities, risks and management plan. I think we are happy to endorse the proposed next steps, and we've added some areas that we'd like you to go back and explore with colleagues around sort of as part of the detail of the development of the plan. Is that okay?
That's great.
Great. Thank you very much, Richard. We move on then under risk. Anne, is there anything that you'd like to mention about COVID-19 and system-wide winter planning, which is our traditional item that we routinely include in this section? Anne.
Thank you, Kristen. I'll just give a few lines on that. I think since the last time that we met, we've seen an increase in presentation of COVID at the acute hospitals. So it's just notable that we might not have huge rates, but the complexities related to COVID are very much still there. So a real push for the vaccination programmes for staff and also for our vulnerable patients is really important for all organisations moving forward. So we are very much focused on that, and Linda's leading that in the vaccination group. We have been fluctuating in OPAL levels across the system. I think we can feel that the chill in the air is indicating winter is very much approaching, and the Urgent Care Board is very focused on its winter plans. A lot of that is around how we organise what we've got to make efficiencies and be able to support more people. And particularly, we're going to hear around the Pathway 2 presentation in a little bit. That is part of that work, but also a real focus on community working, which obviously is very important to us, and alternatives to admission to acute hospital. So they are going to be really key this winter. And I think that's something we should bring back, how we're developing those areas with partners to a future session. But that's a very key focus for us at the moment.
Thank you, Anne. And I noticed and I have to confess, I picked it up on social media. So this is, you know, I'm not saying it's absolutely, well, it must be accurate because it was actually from an acute hospital, an acute hospital, not one in our system, had reintroduced mask wearing in clinical areas because presumably of heightened COVID. In patients with COVID and heightened risk of COVID. Is that under review? I mean, I know there's no national change in that position. So I address that to you, Anne, but I can see Julie's put her hand up.
Julie's coming in because I know we went for some, and the acutes in particular went for some guidance, and that hasn't come in for them as yet, but we're very close to that. And I'm sure Julie's got more information on that, but it's not required at the moment. Julie, I don't know if you want
to. Julie, you're on mute.
Not good on Teams this morning. So it is something we're mindful of. It's something we're reviewing all the time. We are certainly in outbreaks reverting to appropriate PPE for COVID. And, you know, we've got flu coming as well. We need to be mindful of flu. So we will continue to review it in the trust. I'm not saying it won't happen or it will happen, but it is something we are continue to review the risk on a regular basis. It's something I'm talking to Jenny Boyce, our head of infection control, about on a regular basis. We understand there's going to be no national guidance on mask wearing. I think there may be some regional guidance. I haven't seen it, but I did hear rumours that there might be. But it is a risk that we are monitoring all the time. And talked very much about the COVID vaccines. I'd like to add the flu vaccines onto that. For, you know, we're just about to launch the staff campaign in October, and actually, you know, patients and carers, you know, it's important that they get their vaccines as well. We must make sure that we keep staff, patients, families, relatives, and everybody safe this year, both for COVID and flu. So I just wanted to add that as well.
Thank you. So we'll keep that. We'll obviously recognise that we're keeping the sort of the risk situation around COVID under review, and what that might mean in terms of mask wearing or any other expectation around management of that. Thank you for the update, Anne. And yeah, let's take the opportunity to reinforce that reminder about appropriate people getting the vaccinations, particularly flu vaccine, which obviously a large number, well, certainly for our workforce is really important, as well as the people in the community. Okay, the next item we have is the Integrated Assurance Report, Committee Report. So Judith stepped in to chair it, I believe, again. So Judith, over to you.
Thank you very much. I'll keep it brief, and I'll take. So I'll assume that the two-pager is read. The three things that I'd like to draw out from the meeting was that the deep dive that we had was on strategic financial risk to the trust, and it was a very rich discussion. Which, following on from those who attended Performance Committee, which happened to be on the same day, gave us a very detailed assurance, but also understanding of our financial position. The alert and advice unfortunately stay the same from the last reporting period. The alert is around agency expenditure, which continues to not be in a good position. We're not meeting our targets, although we are receiving positive assurance of the work and the intervention that is being carried out across the trust to bring it within appetite. And the advice item is on the workforce dashboard, where the key performance indicators are not quite where the trust want them to be. But we are receiving, again, a lot of assurance and a lot of very good, solid assurance as to the impact of interventions and what is actually being done to manage that the workforce risks, specifically around turnover. So the other items are all under assure, and I don't intend to go into detail. So that would be the report from the Integrated Assurance Committee, and I welcome the Tim stepping in as chair for the next reporting period.
Thank you, Judith. I think Tim has agreed, hasn't he, that he'll be taking over. So he's not here today, but we did pin him down for that before today. Thank you, Julia. Anything to add or comment?
Thanks, Chrissy. Just an additional aside to say that we talked through the first alert around agency expenditure with our governors at our Council of Governors, just how we as non-execs gain our assurance around some of these important issues. But just wanted to add that in as an extra to that. Thank you.
That's really important. Thank you, Julia. An important area of assurance for governors as well. So thank you. If there are no further comments or questions on the AAA report from the Integrated Assurance Committee, I suggest we move on now to the integrated performance section of the agenda to make sure we've got input into that. So over to Judith again, actually, for the assurance report from Performance Committee first, if that's okay. Oh, Judith, you're on mute.
Yes, apologies. I'm actually just scrolling through to ensure that I'm discussing the right one. Didn't expect it to come up quite so quickly. Apologies. Again, I will take the report as read. There is nothing to alert the board too. However, there are 3 items that I'd like to address under advice, and I'm going to do that in sort of reverse order. The first is the estate's 5-year plan. So as board members are aware, the current 5-year plan expired 2 years ago, and since then we have been working jointly with LPT, with Arcus, who has been doing quite a detailed piece of work to deliver a strategy and a plan. But unfortunately, to date, that's not yet been delivered. And that's why committee took the decision to have this item as advice. We now do have a very solid undertaking that we will have a strategy, but in light of the committee just felt uncomfortable that we don't currently have a plan, although one is being formulated. And the other 2 pieces that we wanted to escalate under advice was really around the finances. Initially, so to start with the trust financial report for month 4, we had a very detailed discussion, as I've already alluded to, as to where we are and whether and what we had to do in order to make break even. And we also discussed what we would need to do to work with the ICB in going forward for the remainder of the financial year. And that was a very useful discussion to have, an understanding to have as what we would need to do and the timing of that more than anything else. And under the value programme, we'd received in a separate report for the first time a detailed breakdown of the value programme. So the value programme was previously added in or part of the financial report. Now we're receiving a separate report which really shows that we're focusing on it. And we received a lot of assurance as to what it is that we need to be doing. But clearly there needs to be some further work in this area to deliver the savings that we need to be making. Under Assure, it's all the standard assurance reports that we received, and under Risk, again, we linked our discussions to the BAF and received some clarification that we required for both CAMs, which is going to be de-escalated to the Corporate Risk Register, but also around cyber risk. So I will leave it at there and happy to answer any questions.
Thank you. You did really good detailed report. Any questions or comments? Okay, thank you. Noted, Judith, thank you very much. So we move on then to the paper J, which is the integrated organisational report. And I think we're stepping into the shoes, David's shoes for that. So I'm going to hand over to you.
Thank you very much. And I'll try to step into those shoes. But Dave sent me some key things that he just wanted to pull out of the report today. I think it's great to see this evolving, and I know that the teams have been working really hard on it. I'm going to take the overall report as read, just picking a few things out of the executive summary. I think it would be pertinent to pick out some of the waiting list information. So we did see a slight improvement in August, which is always positive. And we're still tracking at the end of August with a high amount of people being seen within the 18 weeks, which is promising. I think there's so many contributing factors to wait lists, and some of that's seasonal, some of it will be around strike action, some of it will be around just complexity of people coming through, and the teams are working really closely at tracking that and really understanding it. Particularly, we've got very clear processes in place around MSK, which historically has been through COVID and since a really concerning wait list. And this very much is still heading in the right direction, and their very focused project group is seeing those results. And I think we've been working really closely on getting them improved estate to see more people. And I think it's really to celebrate the work the team are doing, while recognising we've still got some way to go. We also have a number of children's waits, which I think is always concerning. I think it's raised in one of Robin's papers later, just around quality. We're doing some really quite focused work, particularly around ADHD, which is nationally a real concern for our country. But we are very focused on that here and working with LPT about how we get the best for this population that is growing. We are constantly flagging this with the ICB and our wider system partners to work together on this. And we're reviewing all of our weight areas that for children, just to ensure that we've got sight of any key risks. Other things that have come in this report, obviously we're outlining some of the financial performance, which I know is coming out in other papers. That I think the bit that I'd want to pull out is really around the value programme. So we've delivered 5.7 million of that out of the total expectation, and we're still working, and it's a very focused programme that Dave's leading on that, and that continues. I think I'll leave it at that for points to raise, but I'm happy to take any questions.
Thank you, Anne, and no doubt your executive colleagues will support you with answering questions as well, as it's an integrated report. We'll open it up if we need to. So let's just bring in some questions. Robin first.
Thank you, Anne. A very detailed paper, of course, as usual, and obviously some really good things going in the right direction. But I did want to flag up about the ADHD because it does come up, as you say, in the quality report later. So if we cover it now, we don't really need to cover it later on. But if you could say a little bit more about the plans that are in place to try and reduce this down, because this is an area which has been persistent, and this report shows has got a little bit worse on this one. So can you tell us a little bit more about what's being done? Explain a bit more about LPT's contribution to that.
So where we are at the moment, I think we always see a seasonal effect on these wait lists because they all will revolve around certain holiday times, etc. Whether that's families experiencing challenges during the holidays down to end of school reporting times. So we have to take the whole year really to get the real understanding. So the work we've done with LPT is just really to benchmark and check, are we doing everything that we can do? The teams have got a really always challenging their process from beginning to end of the wait to the diagnosis, and whether there's any saving within any of the activities there, whether any partners can support, and also as our services in the wider sort of area, for example, our mental health in schools, as they're picking things up, very early prevention, whether we can get people sort of seen earlier down the pathway, so preventing some of the complexities. So we're constantly looking at, as we evolve the wider children's services with our partners, how can that support in sort of taking any time out of that diagnostic pathway, and how we do that. One of the key things that has been put in for a while now that's really key is the clinical harm reviews and the contact and support while people are waiting, because that will have a benefit on firstly people attending, because at DNA is the thing you want to avoid where you have a wait, because that just moves people around. So that's one of the key things. How do we drive any sort of DNA down? So engaging really early on, and also thinking about the support the families are getting during that time and how they're managing in the community. So I think the clinical harms are really important, but LPT and ourselves constantly want to challenge ourselves that we have tried, we're working on everything that's in guidance, but also that's practical to do within our communities. And if we find a new thing that makes a slight difference process, then we want to share that straight away, because we both know that this is a challenge, as I say, for us nationally, but we're picking it up in the group together.
Krishni, can I just follow that up a little bit? Because the other point I was going to say was that there was a great deal of attention paid to it in this week's West Side Constituency Forum with the governors, who were very firm in raising it as well. And this is clearly an area that's of real importance, and it's really welcome that you're comparing notes with LPT and challenging each other. To what degree has this also been taken up with the ICB?
Yes, it's has been a regular feature in their quality networks in the past. It's a regular commissioning conversation, but it's one of the 7 priorities that we put forward for children. That is system-wide discussion, and yeah, because we're attending some national forums on how people are working together. That's shared across all of our system, the ICB, and also social care, because a huge impact on education, attendance at schools, and and important factors like that for our young people.
Thank you. Thank you, Robin. I do think this is, sadly, this is this is pervasive, unfortunately, certainly across the region. I'm not cited on what's going on outside of our region, but I do know that this is sufficiently, I think, challenging that there, well, actually have been, as Anne rightly says, have had some national discussions. And I think there is some work just started, I think, to try and find, pilot some different ways of working that might then be able to be implemented across the board, because it's so significant. I mean, the size of the waiting list across the region is significant. I think Dave gave us a figure at the Council of Governors, which is pretty shocking, but I think that's replicated sadly across the board. So there is some urgency, I think, behind this, and it's certainly been raised around by. I'm pretty sure that it's been raised at sort of by the regional director at QSRMs, for example. So so clearly a lot of work to do. I think we need to try collectively to make sure it's on everybody's agenda, including the systems. And I think for all of us who participate in those system meetings, how do we work together to try and address that? And I think Anne made a really important point, and I know we've discussed this before, about what support can we give to people. It's difficult, I appreciate, but what support can we give to people to navigate, to signpost people to other resources, for example, whilst they're waiting for the service. So a lot of important points, but no easy solution, I don't think, unfortunately, to this. But the benchmarking point is really important, because we need to keep abreast of any developments in other areas that would help us get to grips with this more quickly. Just before I bring everyone in, I just want to check, does anyone else want to comment on this area, or because if you do, I don't want to sort of move on to another topic. So I'll just bring in Melanie. I think you want to come in on this topic as well.
Well, I do. I have a second question as well, which I'll wait until after you did. But on this topic, I just wanted to say, I think it's also really important to recognise that the waiting list is for diagnosis. And diagnostic, and there's obviously a need for real innovation in the way that diagnosis can take place. But what I think we also need to shine a light on is, once you've cleared a waiting list for diagnosis, you then have the support required for children and adults who've received a positive diagnosis. And so this waiting list just represents the crest of a wave of support that follows behind it. And I think it's really important to recognise that and not just focus on the diagnostic waiting list. Thank you. I'll come back in, if I may, in a minute, Krishni, with my point.
Yes, of course, Melanie. Yeah. And also I think just to be mindful of the fact that, this is all linked to educational health plans, isn't it, in relating to schools, and actually one is sort of, they're all linked. It's a systemic issue for us all, which is why it's a difficult and challenging one for us to address. But it's a really important point, Melanie, that that's just the first step, really. So who else wanted to come in on this? Itai?
Yes, I just wanted to sort of say that I've been having conversations with Anne about how we really needed to refresh our kind of clinical diagnostic model to keep pace with, with the diagnostic element. In a service visit, we discussed with the clinical lead about the use of, applications that can be used for inputting some of that information and reducing the clinical time, and how some organizations in the region were using these, and we're seeking to sort of use some of those innovations to try and aid the diagnostic process, make it slicker, and also be able to sort of get treatment to people who are on the waiting list and have been for lengthy periods.
Thank you, Ty. That's really helpful. Thank you very much for adding to that. Okay, so I'll just take it that everybody else had a hand up for a different reason, if that's correct. So you did first.
Thanks, Krishni. And if I may just add in relation to your question, Robin, about raising it the ICB, a delivery and performance just early this month, I have actually raised is to ensure that the risk that is currently captured in the ICB risk register CAMS is there, but it's not very clear what aspect of CAMS is an issue and should be captured on the register. So I raised this issue to ensure that it be clarified. So Anne, thank you for the report. I mean, I really enjoy looking at the continual development of this report. I've got a couple of questions. One with regards to the single oversight, the services are highlighted to have a single oversight framework nationally. So for a clarification, is the target that we currently have in the report the national target or our own target, or does the national target feed in at ICB level and we have to feed into that? I'm not clear in my own mind on that. And secondly, and apologies if I got the wrong end of the stick here, but last time I saw this report, it included the corporate services, which is part of our value programme. So it'd be really interesting to track that through the integrated performance report, but also a more sort of detailed finance. I know it's under development, but I was going to ask when it was going to be developed. And I know that I discussed this with Dave recently, and I expected to see some numbers, and I think I've either missed them or they're not there.
Okay.
Anne, do you want to come in on the first point that Edith raised?
I'll ask my colleagues to join as they can, because I need to check to ensure I give you the right information on the single oversight framework, Edith. I wouldn't want to mislead. I'm not sure whether any of my colleagues can give an affirmative.
I can say, so these single oversight framework is a national set, so the data is nationally determined, Judith, and then every ICB as well as ourselves and NHS England will look at our performance relative to that.
Okay, thank you.
Thank you, Anne. Sorry, Anne, back to you.
I was just going to say, was the next question around the development of the finance and the numbers? I'll have to ask Dave where he's at with that to see what he can update us on.
Okay, thank you. And corporate services, they did used to be there, and they're not part of the report. Same thing. Okay, thank you.
I'll ask him. I will ask him. I've written them all down.
Thank you.
Paul, did you want to comment at all?
Yeah, just very quickly, Krishni. So yes, the answer to Judith's question is that yes, we will develop the finance section in here so that we can make it clear about where we are, both in terms of year to date, how that's impacting on our forecast delivery going forward, and obviously crucial to that is the value programme, of which the corporate services review and savings through there is an integral part. So we'll bring that forward to the next board meeting, the next version of this report.
Fantastic, thanks, Paul.
Thank you, Melanie.
Hi, yes, I'd probably like to suggest a topic that may be picked up by the next Integrated Assurance Committee, because I just wanted to delve a little deeper into the levers. And I'm looking at the fact that in the month there were 66 levers and we account for 19 or 21, I think, in the commentary, which leaves the vast majority without any understanding of what's happening there. And I'm just wondering whether there are key trends in terms of employment elsewhere. You know, are they leaving the sector? Are they moving to local employers? And I think it would just be interesting to understand that a little bit more from a workforce migration perspective, if you like. And we can do that in the Integrated Assurance Committee, I think, please, Robin and Tim, if that can be maybe picked up for a little bit more of a deeper dive next time.
Chris, I don't know, I saw your hand going up in response to this, but I think Melanie's not suggesting we talk about that now, but that it's picked up through that committee. Is that okay?
That's fine. Just to assure the board, we do have the figures on that and we do look at them. They're just not included in this. So people go for life choices, career development, all sorts of elements. So we can, if we want to do a real deep dive on it, we can do that. So yeah, I'll talk with Richard, with the chairs, and look at how we take that forward.
Okay, thank you. so we can certainly note that as an item for that. I don't know what the plan is for the next meeting, but it may be, Melanie, something we need to factor into a forward plan for the committee to look at. Final comment from Angela?
Yeah, just a couple of bits. I'll just pick up briefly on the corporate services that was mentioned, but just to give some assurance, I know Paul will develop the reporting, but just to give a sense, as at month 5, delivery is about 486,000, and we have profiled for the year to deliver about 1.28 million. So just to give a sense of that work is underway, but I think absolutely we need to make sure that that is reflected fully in the value programme and the financial reporting. The point I was going to make was around the supervision position, which is obviously low and would cause concern for us all in the organisation, I'm sure, because that will affect core services, but also trust in terms of well led. Now we know that often supervision is happening but not recorded. So I just really to make sure that we have a real look at that across the directorates, please, to make sure that that recording is being done. And if there is any sense of the supervision not happening, that's also escalated. But we can't stay at those levels. I know that they're probably not reflective of the position, but it's really important that we draw that risk out, please.
Thank you, Angela. So we definitely need to note that and action it. Melanie, it'll need to be brief.
It is very brief. Just to say there was a good discussion on that at the Wellbeing Steering Group yesterday. So again, from an assurance perspective, I know that that is something that is being taken very seriously down through the ranks as a staff wellbeing as well as from a clinical perspective. Thank you.
Thank you very much, Melanie. Chris and Julie, I've got hands up, but we really need to move on. So was there something you wanted to come in on specifically?
Just the supervision, because it can depend on where it is in the quarter, so we can go and look at that, because obviously this might be in the second month of the quarter, but go and look at it.
Okay. Thank you. Was that the point, Julie, you were going to make as well?
That was going to say, because the quarter would finish in September, wouldn't it? The end of September. So actually, this is not a full quarter.
Okay. So important to note and just get the assurance, which is, I think, the helpful that the additional points have been made. So thank you. I mean, I think we've rightly spent quite a lot of time talking about the ADHD and autism waiting list. It is a significant, it's been an alert now more than once on our AAA reports, and it's clearly something we recognise as a significant area of performance challenge for us. So it's right that we spent time talking about that, and I think helpful to get the insight as to things that we're doing on that. As colleagues, I think, have indicated, governors were really interested in what we were doing on that. So I think this is an area of ongoing focus that we need to make sure that we keep them up to date on. But generally, just to say, I was pleased to see also the improvements around out of area placements, although I noticed some national change in language about out of areas placements. There was a sort of different way of describing it, I noticed somewhere, but anyway, it's good progress, I think, and we should acknowledge that, because that is also a significant area for in terms of cost and patient experience and quality. So really important, and I think colleagues have reflected their really the positive development of this report, which needs to be reflected back to Dave and all of the team who've contributed to that. So thank you. We note the report and we've reviewed particular areas of risk, which is what we were asked to do. Now we've got 7 minutes before we let Anne go, probably slightly less than that, maybe 5, to give her a chance to get to where she needs to go. I know there is an area, the Step Up and Step Down community transformation was an area that you were going to lead for us, but do you want to kickstart it? And then I think David may be able to sort of take over at a point that, if that's all right, David, if we need to continue, it may be that we can't we'll deal with what we can, I think, whilst you're still here. Does that make sense?
That's absolutely fine. Do you want me to share the slides, or are we okay just to look at our own?
share the slides, I think.
Yeah.
Or no, does everybody, has everyone got the slides?
Should be in the pack.
In the pack, okay. So actually, if everyone's got the slides visible, then I think you can just talk through them.
Yeah, okay. So really the main focus I wanted to share today was that we have been working on our pathway to provision as a system. This is the pathway to is people who leave hospital, leave an acute hospital and require to have rehabilitation in a bedded option. And
I'm sorry to pause you, but I know I haven't got the slides in Diligent. So I'm afraid they haven't been shared.
Oh,
Certainly not with
them.
everybody, so you
Yeah.
might need to share them.
Sorry,
yes, please. I don't have them.
Just let me share them. Sorry.
Have you got them, man? Oh, yeah, you're there.
Yeah. Are they showing? I've now got
Yep.
a blank screen. Are they showing on the screen okay?
Yep.
Right, so sorry, back to they're talking about pathway to people who leave hospital who require a rehabilitation in a bedded option. Now, this has had a number of challenges over the years, as we've discussed over time, in partly around estate, but also thinking about our population needs as our older population grows, and therefore the requirements for all of our pathways are going to become much more in need over time. So we've had a working group that's been working on this across the system, and we have been to the Health Oversight Committee of both North and West Unitary Councils to talk about some key factors. And what is the good news is that both oversight committees have approved us to continue our transformation journey around pathway 2. So our challenge really, other than there being a growing population, is that often within our community, we've had health beds and we've had social care beds, and they've been in separate buildings, separate parts of our county, and we would often come to the situation for our service users that they would need to leave hospital and there wouldn't be we might have empty beds in the community, but they're not the right kind of bed. Either social care in need is there, or a health need, or the geography is not actually right because we haven't got a wide enough spread of geography. So really challenging conditions of thinking, how do we get people into the community? People will therefore stay in acute hospital longer, which we know affects their overall outcomes and how they decompensate with their ability by staying in an acute hospital for longer. So we really wanted to look at how do we support people to get to the right place for the right intervention. This map here just shows you the beds that are available at the moment, and you'll see there's a reasonable spread across the county, but you will note that there is also in Spinneyfields, which is vacant of colour because that is an empty building at the moment. So we have a range of beds which are really very well used, but we haven't got a full complement. So within the work that we've done in Pathway 2, we haven't wanted to sort of disjoint it from all the other amazing work that's happening in the community around not only do we want people to have the best route on Pathway 2, but how does that link to the ultimate aim of getting home and having a lot of technical aids, virtual support, wraparound care in homes to be able to ensure that we're always looking at the next reablement stage in someone's journey. So all the work we've done on Pathway 2 has been around how do we link this into a lot of the technical developments that have happened for this population. So what we, and we've talked at board at many times, the next development was really to say, let us look at how do we have an integrated health and social care model. And that we, rather than having separate units, how do we bring the staff, the multidisciplinary staff together to be able to support the population so that all of someone's needs can be met at the same time. Turn Furlong has been opened. It's been an exciting development. There's been some real, how do we make this work? You're bringing two organisations together with some quite different rules and regulations, but the team really feels like a team. and we've seen some real benefits for people. So whereas Turn Furlong as a social care provision was always part empty and had very long length of stay, now we've got to the position where we have got very good capacity levels and our length of stay has reduced. I think one of the things that is difficult for health colleagues to see is that our length of stay was traditionally lower than social care because of the complex needs that people have to get into the community. But for social care, for their length of stay to come down to the 40 level was absolutely outstanding. And I think that's been really quite celebrated. That has peaks and troughs because length of stay is measured by the discharge date. So obviously you get someone who's been in for a long time discharged, that will have some spikes, but it's showing really good progress. And now Pathway 2 wants to take on the modelling that this health and social care integration in one building is making a real difference for people. How do we grow this more? So we took to the oversight committees the desire to continue to grow these facilities, to actually look at some of the challenges of our estate by saying which is the best estate to have an integrated model that gives the wide geographical spread and importantly uses really good high-class buildings like Spinneyfields, when at the moment that's completely empty, so not being used by our population. And we had very good sort of positive feedback about saying, yes, we want you to continue with this journey. As with a lot of journeys, there is a lot of work to do behind it. We've already seen in Turn Furlong that it's absolutely committed as a joint model, and we're seeing that that continues. But we have started a process in Thackley Green, which is in Corby, to start to develop their model at a place level. So we're starting to see the green shoots of a new integrated model happening. Already that's impacted on positive flow for Kettering General Hospital. So as we're getting the opportunities, we're developing integrated responses. And this is really where we feel is going to be our drive forward through the winter and into the next years coming to meet the needs of our growing population of elderly people. This has been seen very favourably across, well, nationally. The BBC have been in to understand what's been happening in Turn Furlong and sharing the good news. Not saying there's not learning, there's always learning, there's always new things to do and to challenge and strive for, but it's been seen as a very positive step forward. So I'm really pleased to share that the next steps really for us is that we start developing across the system how Pathway 2 continues this transformation journey of integrated care. I think that's probably the presentation done.
Thank you, Anne. It's a really good vignette, isn't it, of integrated care, really genuinely integrated with social care working in practice. And I know Councillor Golby, who's also a partner governor on our Council of Governors, has been keen to share this and highlight this as a really good example as well. Any comments or questions before we let Anne go? No, well, thank you, Anne, for the update, really helpful, and thank you for your contributions to the meeting so far. Thank you.
Thank you. Take care.
Thank you. So we'll get back in line with the agenda now. I hope people haven't been too confused by the slight choppings and changes that we've had to make just to manage that. So we've obviously covered our patient story and risk item earlier. We just need this morning now to conclude before we have a short break on our strategy section. So we're on to back to the beginning of item 9 on the agenda, which includes a number of papers and updates. So first of all, in that section, we have our general environmental analysis. So Angela, is there anything you want to just update us on about what's going on?
Just a couple of things for me, Krishni, please. So just to share that LLR Integrated System are advertising their ICB Chief Executive role now. So just to put that on people's radar. Also, since we last met, we have had an announced CQC inspection ourselves here at NHFT, and that was on our acute wards and PICUs. So again, just to put that into the public domain. We mentioned PSERF earlier, I think you did, Krishni, but I think just to say that in the East Midlands Alliance, we have worked jointly. Our approach has been very much a joint one in this space, which I think is also important just to recognise. And we have been asked by the National PSERF team to share that approach that we've taken across the East Midlands. The East Midlands Chief Execs are also meeting with the East Midland ICB CEOs in December to talk about how mental health will be looked at as ICBs get more delegation, etc. So that will be an important meeting. And I think finally, just to mention that the Midlands and East group of CEOs have also written to the National Mental Health Director, Claire Murdoch, on the ADHD waiting list. So just a few things just to share. Thank you.
Thanks, Angela. Really helpful. Okay, so we move on then to the formal papers within this section. So first of all, my chair's report, which I'll just take as read, but I do want to just welcome Councillor Dorothy Maxwell as the Partner Governor for North Northamptonshire, who we recently inducted and who will therefore be a member of our Council of Governors going forward. We also want to acknowledge that Krishna Yatharaj, who's one of our very excellent consultants, who has been a staff governor on our Council of Governors, unfortunately has had to step down, really because of his clinical workload. I think colleagues will recall, Krishna actually runs Carers Corner, which is a really, really important initiative which supports carers who are actively supporting our service users. And unfortunately, that clashes quite routinely with our Council of Governors, and quite rightly, Krishna has prioritised that, which we fully supported. And just more on a sort of in terms of NEDs and chair changes, obviously just wanted to say that Julia shortly will be and has sort of started taking on what we're loosely describing as an enhanced role around to support me, just obviously because the new development in relation to myself is that since the last meeting, I've now taken the chair responsibility for Leicester LPT as well. And so in that context, Faisal, who colleagues will know at LPT, and Julia are just taking on an enhanced role to make sure that we have the bandwidth collectively to continue to support the board and undertake all our collective responsibilities. So I just wanted everyone to recognise that and support Julia too, which I think is important. And to say we are in the process of just asking for evaluate feedback for a number of our newer NED and Associate NED colleagues who wanted to participate in the process for receiving some 360 feedback. So really appreciate it. I know exec directors in particular, I've always got a number of other pressures, and also NED colleagues who are doing a number of different things as well. But I'm sure colleagues would welcome your input to their development. And so any time you can take to provide feedback through the evaluate feedback process would be very welcome. So that's all I wanted to say. If there are no questions or comments on any of that, then I shall hand back to Angela for the Chief Exec's report.
Thank you, Krishni. And again, just a few things I'd like to highlight, please. We continue with strike action, and I know that Anna's gone to a meeting on that as we speak. So I just want to say thank you to all the staff who are supporting us to keep safe during these periods of time, and to recognise that that does affect everybody, but important just to note that that continues. Of course, people will have seen the Lucy Letby news and inquiry and the media that's gone with that. I think important at this time that we stay kind and compassionate to everybody involved, and just to signal that we as a board will be looking to take any learning as you'd expect from that inquiry. But meanwhile, we're reminding everybody to speak up and to recognise the importance of safety for everybody across the organisation. We've also had our annual general meeting and we've also got our quality awards coming up this week. So I want to just say a thank you to our communications teams who support both of these significantly. And I know that without having gone to the quality awards, I'm sure it's going to be a great event. And the fact we've got a face-to-face event once again in NHFT is really, really welcome. So I look forward to that tomorrow. Just want to also signal that as part of our work Together Against Racism with our group partners in LPT, we were once again recognised in the UPNA Awards recently for the work that we've been doing under Chris's leadership, and that was an outstanding contribution recognised. That's the second year running that we've got that, so credit to everybody. There's still more to do. Again, we're not saying it's all done, but it is important to get that recognition of the work that we are seeking to do. And I'm pleased that the Reach Network also connected with our KGH and NGH colleagues last week to come together to celebrate the staff networks. I know Chris was able to attend that event, so that was really important. Thank you to them for organising it. And then finally, just to say that Jean Knight, our former Chief Operating Officer, who's on secondment to LPT, has been appointed as the Deputy Chief Executive Managing Director. And I think we would want to send congratulations to Jean formally through our board, but also to recognise the talent management that we do across the organisation and the group and the opportunities that can bring for people on secondments or through joint roles. Thanks, Krishni.
Thanks, Angela. And yeah, I'm sure we'd all want to join Angela's suggestion of you know, celebrating Jean's appointment at LPT and send our congratulations to her. And just to say, the APNA Awards, which is I think it stands for the Asian Professionals National Alliance,
yeah.
which is in essence a network of leaders of Southeast Asian heritage. There is a certificate that we can display as a result of that, and Faisal, who's the deputy chair at LPT, brought that back, and I think we'll make arrangements to display that certificate which we got. And it was a really good event, actually, because Amanda shared a message. NHS Providers Chief Executive was there to present, as was the Chief Strategy Officer. So it was really well attended event. Naturally, there was a huge focus on diversity and inequalities, but there was a very useful overall context to that as well, which I think meant it was great that Angela and I had the opportunity to attend that. Along with other colleagues from both organisations, actually. So thank you, Angela. We'll receive and note your report. So final item on this agenda is on this bit of the agenda is paper H. David?
Thank you. So coming to you today for support for our social value charter. And I think what I wanted to reflect was the fact that actually the NHS does an awful lot of social value and ways of working and support, whether that's people doing talks in schools, our engagement with voluntary community groups, our employment service helping people in. But at a governance level and a big oversight of a board and championing this across the organisation, we haven't previously adopted a social value charter. And what we've done is we've looked at the importance of saying, while this is something that we all do in NHFT, it's important that we recognise and champion it as an organisation, and therefore we help to drive it forward. We report on its performance and our ways of working through. So we picked this up as a group piece of work and worked with colleagues and staff governors to have a conversation about what should be in our charter, and it's presented there for us to approve today. If we approve it today, then we'll have a further conversation with our communications teams and look for a launch and a way of working through. And we'll record and report that as part of the quarterly updates we do around Digby Q and our strategy and our deliverables. Just as a very brief reminder, I think by approving this and moving forward with it, actually we will go forward with additional environmental economic benefits. I think we'll build our capabilities and strengths in this area more. I think it really will link into some of the challenges and the work we want to do about bringing new people into the organisation, supporting new roles, apprenticeships. It is also a fundamental thing that we must do if we're going to be able to bid for, win and retain services, because it is part of the Public Services Social Value Act. So we've taken the way of working and we've looked at the national areas of work and said, you know, our charter should focus on those, which is why we've got sections on organisational resilience, economic inequality, climate change, economic opportunity and volunteering. So I hope that helps as an outline. Happy to pick up any questions and then confirm our support.
Thank you, David. Judith?
David, thank you very much for presenting that paper. I'm totally in support of it. I have one question, and that's an observation from other industries that have a similar charter, who have included ethical leadership within their charter, and I was just wondering if this was something that we'd considered. And I'm not questioning that we don't. I'm just saying we already do. So it'd be quite an easy add, and it would also reflect what other industries are doing.
Thank you. Go on. Sorry, Christian.
No, it's all right. Go on.
I was just going to say thank you. What we need to do as we take this forward is then pick up the and so what's. Where are we going to focus our attention on? How are we going to capture it and build it in? And actually thinking about ethical leadership and ways of feeding that in, that would be a really good thing to fit into that. How are we going to capture it? The so what does it mean? The details that we're doing. Thank you.
Thank you, Scott.
Yeah, thank you, Krishni. Thanks, David, for presenting that. I think it's extremely important that we stay on the vanguard of this as a topic. You know, and I think we need to keep pushing ourselves as an organisation. I think it enhances who we are and what we do, and I think that on that level, it's particularly important that we give consideration to that and have a stated social charter that we can continue to develop, enhance, and challenge ourselves against. And I think one of the bits that really resonates for me is that I think, like many other attendees of various different committees, we've gone through a round of updating our terms of reference in those committees to address a key aspect of keeping equality at the forefront of what we do through our agendas through that area. And this has to align with that, because it's absolutely the flip side of the coin of equality is that we need to be looking about what we're going to do about inequalities, and this absolutely plays to that, David. So absolutely key and pivotal going forward. So thank you for presenting it to us this morning.
Thank you, Scott. Julia?
Thanks, Tracy. Just to add in, I really, really like this very much. It's really well written. It looks very clear and simple and understandable. And I think it gives us a real opportunity to actually highlight to people what we're already doing. Then we know the gaps we've got and what we're going to be working on. Really, really like it. And I can already see that it will make a difference to be able to articulate some of these areas much better. So thank you. Really, really like it.
Thank you, Julia. Robin?
Again, really pleased to see this document emerge. It is really important, and it's crucial that we have something that sets out our kind of social commitments. I just wondered if there's a little bit more that we could add to it. And I'm thinking particularly in terms of the choice of the different headings. We've chosen economic inequality, but there's all kinds of other inequalities built into that, particularly health inequalities, which I wonder whether could also form a greater part of the wording. And whether it could be developed just a little bit to emphasise a slightly broader impact upon those inequalities than just within the economic sphere. So it is a great document. There's really good stuff in there. I just would be very keen to see it just a little bit enlarged.
Melanie, do you want to come in, and then David, I'll bring you back in more broadly about how we take it forward. Melanie?
Yeah, just yeah, sorry, I was just pondering on Robin's point, because I think we have to recognise the scope of social value as being quite a discrete scope, and it's quite defined in Department of Health, I think definitions, etc., that we've drawn on. But a question that I had really, because I love this and I think it's really good. My only question was the use of the term volunteering. And again, just reflecting on the work that we've done in the whole area of involvees, as a, you know, who are both peer support workers, volunteers, people who actually participate in other ways. And I just wonder, reflecting on that work that we've seen through the audit committee, whether volunteering might be a recognised term, but I just wonder whether in the body of the text we actually tease out enough about the wider ways in which people get involved, not just volunteer. That's my only thought. A bit late in the day, I apologise. Just reflecting on it.
So, Melanie, thank you. I think, David, in terms of where we are, I think this has gone through somewhat of a process to get us to this point. So I suspect we're kind of in danger of tinkering with the wording and constantly changing it. Perhaps maybe is your preference for us now to think about how to bring some of that to life in how we take it forward, rather than, because I think this has gone through somewhat of a process, hasn't it, David? Do you want to clarify that?
Yeah, so the sort of 5 key headings, that the economic opportunity, volunteering and so on, come from the terms that government use to describe some of the social value stuff. So they're a direct, which makes it really clear when we come back about how we've delivered on those things. But accepting that, therefore, what we need to do is in the what are we doing and how are we feeding things through, we need to think about how do we capture things, how do we feed it back, how do we work some stuff through. We'll go away, and the next stage is picking those key things up, feeding them in and thinking about them. One of the things for us to think about, which we'll come back to you about, has been whether we add social value into the template of the cover sheets for meetings like this. And therefore we start to normalise that across all of the different board reports we're doing. Just need a bit more discussion about how that can also help, because then that will start to, if you think, therefore we start to talk about it in every single thing, as opposed to being a strategy with 3 or 4 specific deliverables. But if that makes sense about why we've got those terms, it's now about how do we implement it.
Thanks, David. So if we can agree, I think the proposal as it stands, recognise that we may want to review and enhance it as we go and learn, I think, because this is going to be somewhat of a learning process. I think there is a reporting, there is a what next piece, isn't there, David, which is, I think, where you're saying we can feed in some of those other reflections that people have made, which I think that is a really good opportunity. And indeed a development, I think you mentioned, of a dashboard and sort of other things that will then monitor our progress. But I think a good simple first step is the inclusion is something that prompts us, and it may be just a simple thing, Richard, we just need to think about within the governance table or within any other sort of changes we want to make to our paper template, that it actually prompts people to think about, and what about social value, which I think is really important. So we're asked to approve the social value charter and support and champion the delivery of it across our organisation with partners. I take it, I think everybody's happy to support it, which people are. Melanie, did you want to make a final point?
Well, it's referenced later in the audit committee report, and I thought it might be more relevant to just reference it here. That we also posed a bit of a challenge to our external auditors about how social value might form part of a value for money approach, and that hasn't been done anywhere. So our external auditors kind of paused and took the opportunity to go away and reflect on that sort of challenge, to put some thought into it. So I thought it might just be interesting to see that social value, you know, should permeate through a lot of things, and that's another area that we touched on.
Yeah, good point, Melanie. Thank you. I think useful to reflect that. So thank you, everybody. We will approve the charter, and we'll leave it to you, David, to work up the next steps as we've discussed, but I think now is our opportunity as a board to champion it at every opportunity. And we did have a really good discussion with governors a while ago, David, didn't we? On this, and it was actually a lot of our governors were really engaged on it. So I think we need to think about how we make sure that it features as part of our council agenda as well. Good work, and thank you very much. And of course, it is important to say this is a joint piece of work across the group, and it's part of our so it will be picked up as part of that as well. Thank you, everybody. So we can take a short break now, I think, comfort break. So I suggest we come back at 11:35 to start our people section. I think we've covered everything that we needed to at this point. And don't forget to turn off your cameras and microphones, please. See you shortly. Just make sure everyone's back. Just give everyone a few more seconds. Okay, welcome back everybody. We are now moving on to the people section of our agenda. Just to say up front, I perhaps slightly foolishly tried to get the fact that we had a number of different RES reports consolidated into one, but I'm not sure quite successfully because they're all at different points. So if it feels a little bit strange to have the RES report and then the medical and bank RES sort of all part of the same paper, you can blame me rather than Chris. And I think just to say that just to remind everybody, we've already seen the RES data. I think we saw that back in May, and this is our paper just demonstrating the actions that have been co-produced. We said that the team would take away the data and do an action plan. So that's why we've got the RES plan, but obviously there are a couple of new elements which Chris is going to sort of talk us through, which is the bank and medical RES. So I think that's a fair, hopefully a fair and accurate description of where we are, Chris. And on that note, I'll hand over to you.
No, I think it is, Krishni. Yes, and obviously there is a lot of detail, but I think that's a good thing in its sense. It gives the board the full overview of what's happening. I just want to pay credit before I start, though, to the EDI team and to David Ledger, because these figures go nationally and then you just get the national data. They've, as it were, taken the statistics and number crunched it in a lot of detail to give us the insight into the challenges we face, which is going to allow us to build some really positive action plans. Do you want me to take each of the three in turn or go through all of them together?
I think, Chris, do each in turn and we'll just pause in between. So we'll do the plan for our RES, then bank and then medical, because I think they do highlight different issues, which is probably worth just pausing on as we go.
Yeah, okay. So in terms of the RES action plan, that's been developed. It's been reviewed by Andrew as the sponsor of the network and myself as the exec with oversight. I will take them as read. I think you can see the detail of what's progressed. And if I pull out two particular examples, firstly, the recruitment ambassadors is now embedded, and we have a recruitment ambassador for every 8A recruitment process. And I think, Krishna, you and myself have had personal experience of that and how hugely positive that can be. And I think that's what people are reporting. And then I thought I'd also draw out the decision-making group, which is where we get senior staff involved in reviewing whether things are going to formal disciplinary or not. People may remember we had some quite concerning figures there a while ago, which the decision-making group then impacted very significantly on, and we've improved that particularly. I think you can see the detail of the progress we've made and the plans that are there to move things further forward. So really recommend it to the board to be assured of the progress and support the future plans that we have set out in the paper.
Thank you, Chris. Just really any comments or reflections on the RES action plan? As I said, this is in response to the data we've already seen back in May. I do want to just echo my personal experience of what was the name, the title? Is it the Fair Recruitment Ambassador?
Yeah, Fair Recruitment Ambassadors,
yeah. Which was just amazing. I mean, it was just really powerful, and I felt the quality of the training must have been really good because the individual managed their feedback to us so exceptionally. I know that would have been, maybe the individual themselves already had some of those skills, but the process was so powerful. And given that, the feedback was to a number of, well, myself and a number of other sort of, exec colleagues, I just felt it was incredibly powerful, and if that was a reflection of the work that was going to be done by other colleagues as well, it just felt incredibly powerful. So I would definitely say that was a huge step in our journey. Julie.
Chris, I really welcome this report. It's got some really good stuff in that we've already achieved and we're moving towards as well. So I think this is a brilliant report. I just have one area I wanted to bring up though. I note that rightly, and it's important that people's names are pronounced right. I'm very much an advocate of that. Having had a maiden name that was difficult to pronounce, I really do understand that. Can I ask that when we look at the tool we're going to use for pronunciation, we consider our colleagues who are dyslexic, and as you know, I'm dyslexic, because a lot of us don't read phonetically. You know, so we need to think about the tool and how it meets everybody's needs, because it is embarrassing when you can't read somebody's name. So I just wanted to bring that to the table if I could. Thank you.
No, it's helpful, Julie, and we can, I mean, the co-production, we can work with that. I think it's a really helpful suggestion. I'll pick it up with David.
Thank you, Julie. It's a really important point, and perhaps our disability network, who I think have we renamed the group? Enabled, I think.
Yes.
Enable, yes, it's going to be
Enable. So perhaps the Enable network can help us with that as well. You did.
Thanks, Krishni. Chris, thanks for the report. Really great to see what we're doing and the progress that we're making. I've got 3 or 4 observations and questions. I was wondering, oh, and by the way, I absolutely love the fact that we are now using ECM, ethnic and cultural minority. That is in itself a step forward. Can I just ask, the 6-step process in relation to racist abuse from patients, perhaps not for discussion right now, but I'd be very interested to understand what the feedback has been from that, and really to understand what we're doing about ease of reporting of this type of incident, and and also to give feedback to people who have reported, because anecdotally, people who do report this do also want to understand what is being done. So that's something that I think is a really important piece of work, and it'd be really good to understand a little bit more around that. And secondly, do we track workers who are white but are not British or you're not from the United Kingdom, because they are also a cultural minority? I fit slap bang in that one, so I do tend to bang on about this, and it potentially could be quite an important minority that we don't actually know about.
Well, 2 things certainly. The 6 steps have been reviewed positively. We do need to ensure resources, you know, are allocated to roll it out, and, as you say, keep a track and review it. And in fact, we've got the wellbeing group. We had a further an issue raised from the Reach network about what support we give people who've experienced it. So it's to assure you that it is coming up, and we're doing work on it. I'm not quite sure in terms of tracking, if you like, white cultural minorities. That's what the ECM name was created for, to include that, and the Reach network also has used that, so it can include that group. So we are including them in the work we're doing. I'm not quite sure how we will track them, but we are considering them and changing things to adapt to that.
That's fantastic to hear. I mean, clearly we don't have the data because we're not required to give the data nationally, but it's something that, you know, we need to think about, that, you know, we exist and we tend not to be recognised. So it's you know, lumping people as white is also quite misleading from our point of view, because yes, you know, our skin colour is white, but we're culturally very different.
And that's, I think, your point. The ECM phraseology includes them, whereas the BAME probably didn't signal that.
Yeah, absolutely. Thanks.
Thanks, Judith. And I think it is, you know, I think the RES data doesn't really, or RES as a national focus, tends to focus on those people who'd be visibly discriminated against because of the colour of their skin. And but I think that sensitivity to other minority groups, and actually we saw that in COVID, didn't we? You know, in terms of inequalities and servicing our community, there were definite challenges in reaching other minorities who were not people of colour, like Eastern European, you know, people of Eastern European heritage who perhaps we weren't reaching more, you know, as well as we could within the COVID vaccination scheme. So so it's, I think, being sensitive to that, even though I think there are some constraints, aren't there, Chris, about the way that the data is collected, because of these are obviously national data sets. Is that, I think, is that fair?
Yeah, well, the res is national, yeah.
Yeah, absolutely. Saqib.
Thank you. So Judith took one of my questions, which was around the ECM, but I just wanted, in an ICB where I'm at, the HR director started using global majority. Is that an alternative or one that she uses? Because I haven't heard ECM before, so I do welcome its change. And I was just going to reflect that I did a DNA test a few years back and discovered that I'm actually half Indian and half Pakistani in terms of the geography. And my older two kids are about to get Irish passports. So depending on how you define it, it's going to be very complicated ticking some of these boxes going forwards.
Yes, when we came to the ECM, that was a sort of co-produced decision. We had quite a big discussion. We discussed the potential use of the global majority, but it was felt that didn't really, I suppose, as it were, represent or delineate the challenge, and is a term that people are really not greatly familiar with. So you know, I think there's a feeling we spend as much time explaining what we meant as actually moving it forward. So yes, it has been considered and discussed at some length, Saqib, and in a co-production approach, we landed on the ECM as the preferred approach.
Thank you, Chris. And I think the co-production piece is really important here, because I think the reason why we've been able to take this forward in, hopefully in a, you know, in a reasonably successful way, you know, this is a really important things that we've been focusing on for a very long time, and been trying to move forward and develop. The co-production with our Reach network, in fact, the renaming of the Reach network was very much a co-produced outcome, wasn't it? So all these things, I think it's really important that we work with colleagues who are within those networks, who want to, who will help us make those judgments. So I think it's really powerful that the term that we've adopted is something that our people feel comfortable with. But you know, different people will have different badges that are used, and we just need to be cognizant of them, but use the terms that people feel most comfortable with within our own organisation. But I think there's some really positive developments here, and I think it's very exciting that we continue to develop in this area and work in this area, and of course increasingly work with our colleagues in LPT as well around these areas. So thank you. So I think, Chris, you just wanted, as far as this RES action plan is concerned, which is the broader RES action plan, not specific to bank or the medical and dental workforce, you just wanted us really to support this action plan as developed by and co-produced with our Reach network.
Just and Christian, if I may, to build on what you said, I shared with exec colleagues last Friday. I was lucky enough to be invited and attend the Reach Network's celebratory events, which was a joint event with NGH and KGH, which was a truly fabulous, energizing experience. I mean, the kind of energy, colour in the room, just the colourfulness of everyone's dress and what they're involved in, and the food they had. And I was, Amelia and Mo were there, and they're expressing their support for the board, support for them, and they realise they are valued and appreciated. But it just really lands how that diversity, creativity, how much value it brings to our organisation. So as I say, I shared that with exec colleagues, but I would share that with the board as well, because I think that's a fabulous living representation of what we're aiming to do.
Thank you, Chris. Right, well, let's move on then to the bank res data. Chris, so back to you on that.
So in the bank data, this is bank only staff who've done a shift in the last 6 months. I'll sort of pull out the positives and some interesting points within it and then move on to the challenges. Interesting, got a high proportion of ECM staff in the lower grades on the bank, which isn't representative of what we have in the permanent staff, where the majority of our ECM staff are in higher grades in the trust. So that's an interesting element for us to look at. The real positive is that 33% of our bank staff are interested in moving to permanent roles. And within the HR team, the wider work, we really need to explore that because we've talked earlier about the agency and the challenges. The more of these staff we can bring on board, the better it will be. And equally, they're also positively seeing opportunities develop their career. Again, the majority felt the organisation valued their contribution and also were respected, and individual difference were respected. So in terms of their experience, there's a lot of positives from this in terms of the bank staff, the information that's come out. I think the issues that the things I would land on as the real biggest challenges are the experience of harassment, bullying from the public, and also physical violence from the public as well. They're really quite high figures. We think that probably is something Deborah Callaghan is doing a big review piece with the bank staff, because obviously you're bringing bank staff in and you're bringing them into cover. And I think, just anecdotally, Anne isn't here, but I'm sure Anne would mirror this, is they might, for example, be put on the one-to-one shifts or in the night shifts or on some of the more challenging wards. So, this is likely to be their experience of safe patient restraint, what's happening, how that is. So this does flag to us an area we've really got to look at. And then equally, when they're coming off the shift, are they reporting those things? Potentially they might feel insecure about it. So there are an awful lot of opportunities here. Now we're aware of this, to work with the bank staff, understand it, give some really positive messages about how they can report that, and also work with the managers. And that's really our focus now, is with the bank manager, but also with the work that Deborah Callaghan is doing to develop a plan that will be co-produced with our Reach network, with members of the bank staff, freedom to speak up, so that we can see how we can really deep dive into some of these issues and further improve the experience of our bank staff. And we are, apart from this, looking at opportunities where we can potentially involve them more in our engagement events and actually target some of the bank staff, because I think that prior to this even has risen up the agenda. I know Angela, I know the whole exec team, but Angela will definitely champion, as I will, that we need to maybe take a different view of the bank staff to see how we do make sure they, as they seem to, feel part of the organisation, but really see what we can offer them to continue to experience the value that they bring for all of us. So happy to take any questions.
Thank you, Chris. And I think that I'm right in thinking this is the first time we've seen this data, isn't it? It's the first time we've collected the data. So obviously this is really new for us to understand the needs and the challenges that this particular group are experiencing. So it's important that we understand there will be another step in terms of actions to be taken, but it was important to share the data at this stage. So Scott?
Yeah, thank you, Krishni, and thanks, Chris, for taking us through that. I mean, I'm probably going to follow up on a couple of the points you've made yourself, really. So, I mean, just noting the fact that, absolutely often it does tend to be bank staff who get some of the more unsociable hours when they're covering for us within the organisation, and that resulting in perhaps people having a bit heightened emotions around all of that. So, I echo what Krishni was saying about the fact that, having seen this report for the first time, it starts to provide some useful insights for us. And following up on what you were saying yourself, I think if I've just looked at 5A and 5B, quite concerning, and something that we'd want to see further progress on, in relation to 12% of white bank staff reporting or seeing that they've experienced physical violence. Well, 12%, I think we would probably all say is too high anyway. But in comparison to 12% to the 45% of ECM staff, that's deeply concerning. But then over and above that, that 12%, 81% of them are reporting it from a white ethnic group, but only 55% from the ECM group. And that really speaks to what you were saying, Chris. Do they feel that they have the appropriate support structures around them? And it's that I think we'd like to hear, you know, the plans on as it follows up. So I think that's pretty key for us. The final comment I would make is one you've already highlighted yourself. If I look at indicators 6A and 6B, we've got right across the board, both white and ECM staff saying they're interested in a career in the NHS, and white and ECM staff saying that they'd love to have development opportunities within the organisation. And clearly that must play centrally to part of our strategy to help us, you know, address any agency utilisation. So, you know, again, I think we'd want to see what the plans are as they develop in those areas, because this sounds like a group of people that are saying, come and get me. So yeah, I'm sure we'd want to embrace that, wouldn't we?
Absolutely.
Yeah, I think
yeah. Chris, can I add a comment to what Scott has said, and then perhaps you can just comment? So I mean, I endorse everything that Scott said, because I think, you know, and you pulled those out in the paper anyway. So there's something here, isn't there, about that, you know, are these people ripe for sort of bringing into our organisation, and what's their experience, that, you know, what kind of experience can we offer them that would help them want to become permanent employees, but or actually keep them happily on the bank but feeling supported. So I think that's important. The one thing I wanted to add was, I suppose I feel like we need to understand why such a high proportion of particularly black staff are, you know, 32% of our active bank workers are black staff. I don't know, that feels like it ought to be. I don't know whether that's the right balance. I'm not sure. I mean, if you look at the substantive workforce, it feels a bit of a strange number. And I do worry whether that is, why is it out of choice that people are choosing to be on the bank, or is it because they feel they won't get another opportunity, a permanent opportunity? So that might be far too easy a sort of assumption to draw from the data, but I just wondered about getting underneath that, really, Chris. So back to you.
Well, I think you both highlight. I think this is where the real value, although some of the figures are extremely concerning, they do sort of offer a chance to find the key to unlock some things. You know, we do need to recruit more HCAs. We've clearly got a potentially captive group of people who want to do it. We don't seem to be unlocking that. They do think we'll develop them, and they like the organisation. So yes, I think we've really got to deep dive into this and find out what's going on and how we can you know, resolve that. But it does, you know, it does give us the information to do that, and as Scott's saying, we need to work on the plans to make that happen, which again, we've got the impetus to start doing that.
Thank you, Julia. Thank you, Chris. I was just about to move us on. Julia, did you want to make a brief comment?
Really brief point, just sitting reflecting about when people report or don't feel they can report incidents and issues, sort of links with freedom to speak up a little bit. And I know we've been talking about that earlier in the meeting. So just to sort of correlate some of this with people's confidence to speak up, because it's a similar sort of area, really. It was just didn't want to lose that. Thanks, Krishni. Thanks.
Yeah, important point. Thank you, Julia. So I think the board is just asked to note the findings. I mean, clearly, as we've said, it's new data, it's powerful data. I think it highlights a number of opportunities and challenges that we need to step into addressing. So we'd absolutely support the development of a tailored action plan in the way Chris has already described, I think. So thank you, Chris. We'll move on then to the medical res.
Yeah, again, so I'd aim to highlight some key points, and obviously I'm sure Itai might want to comment as well. First point, we do have a high proportion of ECM doctors, and the sort of proportionate representation. Interestingly, unlike in the other res figures, the recruitment, it's actually ECM doctors are more likely to be recruited, but I wouldn't dwell on that too strongly because they are small numbers. Again, the medical management, the more senior grades are proportionately represented. I I think what's concerning here particularly is if we look at the people promise, the doctors are consistently scoring 1 to 0.5 below those across the trust. So there is a real engagement piece here. And also the percentage again of them experiencing bullying and harassment are high. And that's a key concern, and we need to work an action plan through that. I think one of the key elements here is to engage with the medical staff and understand what's behind this. And indeed, ITI has led with the EDI and staff engagement teams and HR. There are a number, as you'll see, reported a number of listening events that are planned so that we can understand this further. And there's already been a focus of discussions with medical managers and the JLNC. That's the Joint Local Negotiating Committee, which is the Doctors' Trade Union Forum. So there's a major listening event on the 19th of October where we look to build on this and understand it more. And clearly from that, again, we will be looking to co-produce the action plans with the doctors and HR and the medical management team and EDI teams. So that's where, you know, that's the focus of what we want to draw out of that, having explored that more through those key listening events.
Thank you, Chris. I think, yes, it is quite striking the difference between the trust staff survey data and the medical and dental staff survey data, and the sort of disparity between them. So really important that we go forward in the way that I think you've described, Chris, and I'm sure I don't see any particular comments or questions, but I think we would absolutely support, you know, there are 4 steps described in your Let's Talk engagement plan approach, or 3 steps actually, and it feels really important that we take those forward and support the development of a bespoke engagement plan, which you've described. Saki?
Just a quick question. When medical staff primarily leave the profession or go overseas, do any of them ever mention that it's their student fees? There was something on the radio this morning, I can't remember who's recommended, that they are written off after 10 years.
I haven't got the data on that scheme, I would have to say.
So
ITI's got any comment on that?
Yeah, I mean, I suppose the question is there it's probably useful to correlate the turnover rate, isn't we'd have to look at the turnover specifically.
Yeah, I mean, it's more
guess,
if it was a concern, you know, if we were noticing that staff were regularly either leaving NHFT because they said they couldn't afford their fees or were going to work in the Commonwealth. I was just wondering if we knew.
Yeah, I mean, the only thing I would say is I'm not sure we could do anything about it, even if we did know. So it would be a piece of work that would be useful to know, but we couldn't do anything because it's not within our gift to, unless we choose to pay it off. But I'm not sure that we're in a position to do that really. So interesting, but not. I'm not sure we could do anything about it. Unless Chris, you have a view on that?
No, I think it is, as you say, Christian, interesting but difficult to respond to.
Yeah. Okay, thank you. Itai, did you want to comment?
Yeah, so I did want to comment on that. I think it's important to note that the MRES data is based on consultants and SAS doctors and a career grade doctors, and the majority of the doctors that Saqib is describing are people who are in training roles, and they are obviously have a different lead employer to us. They are hosted by us, but they have a different lead employer. And a lot of the drivers around junior doctors, leaving for greener pastures are usually around, pay-related issues. We can see that from the strikes that are happening at the moment, and there've been a lot of concerns by junior doctors about their conditions of service as well, as their pay arrangement. I think that's usually the key driver for people going abroad. And also we don't pay as well as Australia does in a lot of cases, and that's been a big draw for people sort of seeking a career break from working in the United Kingdom and migrating to either Australia or the Middle East.
Thanks, Itai. Really helpful insight, I think. Melanie, final comment, please.
Yeah, just reflecting over all of these, the 3 areas of the reports, and I think we've touched on already the reduced level of reporting, which I think is a combination of personal decision as to whether to report it or not, and potentially some obstacles in system simplicity, etc., but also potentially some perception of the response and how any reporting will be dealt with. I don't feel that I have a strong understanding of that, and I don't sense in the work in these papers that that is an area of particular focus. So I might have missed it. So
Yeah.
I know you sit on the you're EDI lead on our side, so maybe this is being discussed in other fora. But I just think maybe this is something that, again, the Integrated Assurance Committee should pick up from a workforce perspective. But I think there is more work that needs to be done in understanding why it's not being reported, and how that loop is being closed, and what action is taken when racism and bullying and harassment is reported. And we need to shine more of a light on that. Thank you.
Chris, will you pick that up anyway as part of these other action plans? Because clearly at this stage, with the medical res in particular and the bank res, we haven't got an action plan, have we yet? This is the start of it. So can we pick that up as part of that?
I think we can. I think we do. Obviously, through the Freedom to Speak Up, you get reports which are followed up in lots of depth, and people feel that. But yes, I mean, I think we can take that as another pointer.
Okay, thank you. Itai, finally.
Yeah, I just wanted to come in on the point that Mel's just made. And I think generally people feel uncomfortable about reporting issues because they're fearful of being identified. And when we do the deep dive on the 19th of October, we've thought really carefully about how we manage that and ensure that people can give, frank, open, and anonymous feedback. So we'll be, making use of technology, things like Mentimeter, etc. So that, instead of asking people to verbalize things and potentially be identified, they can sort of submit their feedback anonymously. I think for us, it's important to actually, get a really deeper understanding of what are the issues, because if we are going to develop an action plan that's fit for purpose, we really need to understand, where are the hotspots, what are the concerns, and usually if we make it about the issues, we've got a better chance of addressing, and also gaining confidence from the medical staff that we will do things, we will do something about their concerns and not just pay lip service to them. So this is a start of process that we will do it at the Consultant Away Day, we'll do it at the SAS Doctors Away Day, as well as the Dental Away Days, so that we access all the groups and we get a deeper understanding about what are the issues and how can we help, really, and make people's working lives a lot happier.
Thank you, Itai. Really helpful. And can I just add, and a final word really on this, I think it's really important we think about people who are in training, and junior doctors, yes, but also any other people who are on placement, and whether we're giving them adequate vehicles for raising concerns, because they're even more in a more specialist group, aren't they? They're in a sort of almost slightly, and their feedback is really valuable because they're experiencing our culture and our environment potentially for the first time, and they're bringing a fresh perspective. So how we enable that. So I really like the idea of potentially technological, use of technological solutions that support sort of freedom to speak up, so that we can encourage different vehicles for people to raise concerns. So I think it's really, really positive. Chris, thank you, and Itai, thank you for adding your contributions. Potentially, I think we can look at whether this again adds to the IAC work plan. Richard, I think, in terms of something for further scrutiny, the point I think Melanie was making about particularly abuse and racial abuse and harassment, which I think is just an ongoing concern, isn't it? But I do think we need to give Chris and the team the chance to do, with Itai and others, do the engagement work and the plan so that we can see what's falling out of that, and that might also inform our broader res plan anyway. So Chris, can we leave you to take it forward on that basis?
Yeah, no, that's very positive.
Great, thank you. And please thank David and the Reach Network as well for their contributions to David and the team, the EDI team, for all their work in this area. Okay, thank you. We move on to our quality section. As ever, when we get on to people topics.
Krishni, you need to do WDES report.
Oh, sorry. Sorry, WDES. And we are a little bit behind. So I don't want to kind of start shortening everything, but can I just ask everyone to be cognizant of the fact we are now behind, and therefore we need to be quite tight on our timings. So WDES.
Yeah, I'm conscious of that. I'll just draw out key highlights. I think we can celebrate very strongly that we've been ranked 9th out of 220 trusts for the weighted WDES information, which is hugely positive. Although we didn't win, we're shortlisted for a HSJ award and a Health People Management Association award for our work on wellbeing and neurodiversity. So I think, in terms of this overall, for a level of assurance, we can see we're being recognised for what we're doing, and the group is pushing on. As you say, I think the enabled change of name to more effectively encompass groups such as the neurodiverse colleagues is very powerful. Key successes been the recruitment ambassadors again, the reverse mentoring for the exec team. We've got a workshop coming up to build some further work out of that. We further embedded the health passport, which people are sort of seeing as something that everybody can use. Is being pushed forward, and the network are key to that, supported by the EDI team. So I think it's for the board just to confirm assurance and that we would publish the WDES report. But again, I think good progress is being made. I reviewed the action plan with the network, and I think we've got some more good stuff to take forward.
Thank you, Chris. So again, with WDES, we had the data, I think, back in May, didn't we, Chris? And so this is the action plan that the board committed to receiving once it had been worked on. So some really good things in here as well. Angela?
Yeah, just want to say thank you to everybody for the work in this area, because this was an area of focus for us, and it's pleasing to see some encouraging results with more to do. But also I think to just formally thank those that committed to share their stories in reverse mentoring. It was really powerful. It has made a difference. It is making a difference, but it took people to come forward to share their stories. I just want to thank them for that in our public forum. Thank you.
Thank you, Angela. And we do extend our thanks and endorsement of the plan, if everyone's comfortable with that. Really important area as ever, and it's really good to see the progress that has been made, but with more to do, as Angela said. So thank you. We move on then to our quality section. So first and foremost, we have our Alert, Advise and Assure report, and I think Robin is leading on this report. Robin?
Right, conscious of what you just said, Krishni, I'm not going to spend any more time highlighting the one that we have alerted again for the second time, which is the ADHD waiting list. I think we've already covered that in some detail, and just needs to be said that obviously this was an area of concern, remains an area of concern elsewhere, and one that will obviously be subject to continual seeking of assurance that work is really going on, both at a trust level and at a system level. In terms of the other items, obviously, that we discuss, there's a huge range of papers obviously come through this committee every time, which come up from the lower committees, and we review and consider each of those in turn. And I've highlighted in the AAA report various aspects related to them, but I don't want to draw attention to any of those in particular, other than one example, which is that we discussed and had a very useful update on responses to the recent CQC visit, which was very helpful to get very quickly a kind of sense of the of the real action that's being taken to address the points that have been made. So that was extremely useful. So attached to this report are two reports which are required to come to the board after having gone through the Quality and Safety Committee. One of them is the organisational audit, which came in a draft form last time, but then came to the last Quality and Safety and was signed off. So that is attached for your consideration, but it doesn't require any further detail from me here. And the other one is the safeguarding report, which was considered. It's not formally rated as part of that committee, but it was discussed in some detail. And there was a very high perception of the quality of work that was going on in that area. So that one is also attached for information. So I won't draw attention to anything else, but invite questions if there are any on that.
Thank you, Robin. That's really helpful. So any comments or questions? Okay, so I think we should just note that we have received therefore the annual safeguarding report, as Robin mentioned, and indeed the annual organisational audit, medical appraisal compliance report. And I think we're required to approve the terms of reference, Richard, am I right? So just really to confirm, is everyone happy to approve the terms of reference? I think some of the changes are also linked to the constitutional change that we've got on the agenda, aren't they, which we've discussed with the board before, which is about the role of associate non-executive directors in our committees. So is everyone content to approve the terms of reference for the Quality and Safety Committee? Thank you. Thank you, Robin, for the update. So we move on then to our standard reports from a quality perspective, and it's over to Linda. So first of all, we start with the Patient Safety and Learning Assurance Report, which Linda, I think, did remind me earlier that there was some comment in there about the leader reports because of the point we made about that being part of the Patient Safety Committee. So Linda, over to you.
Thank you, Krishni. I will take it that the report has been read and just make a few highlights, really mindful of the time that we are running behind time. So just to note that we continue to review the top 5 safety issues that we are reporting on. Of closer review of these incidents, I'm pleased to report to you that 85% of these have resulted in low or no harm. I also want to draw attention onto the previous discussion around pressure ulcers and note that with regards to the pressure ulcers that we are reporting on, we are seeing some improvement insofar as how we are managing those and also the reporting that we are seeing from our teams. So this links directly with regards to training. So as we are seeing increased training for our staff team, particularly around safeguarding level 3, where adults, we are also seeing an increase in the reporting. So a direct correlation with regards to that. Again, most of these incidents have resulted in low to no harm. Also wanted to just mention that within the report, we have presented to Patient Safety Committee around a review process for pressure ulcer incidents, and this is a pressure ulcer group within the trust. At the time that we presented to Patient Safety Committee, we had not yet confirmed who was going to be leading that group. So I've taken on leading that group, and we've since had our first meeting for that pressure ulcer group. So we are immediately looking at pressure ulcers, teasing out the learning in them. Are there any gaps that we can immediately ensure that we are addressing? We're also looking at the reporting around pressure ulcers to reduce the duplication in the reporting. So a lot of work being done around that and the management of pressure ulcers. I also wanted to highlight within the report around the incidence of self-harm that we continue to work with service users as well as our involvee groups to manage incidents of self-harm and also ensure that we are prioritizing patient safety. And these incidents are with regards to our inpatient units. Some of them will be attributed to a single patient rather than multiple patients having had incidents of self-harm. And again, for most of these incidents, they will have resulted in low to no harm. I did also want to highlight around our electronic prescribing and medicines administration, because we do have our area of monitoring around drug errors, medication incidents, and where we have implemented our EPMA within our inpatient settings. So some of our mental health wards, like our older peoples, as well as some of our inpatient community beds, we are not seeing an increase of medication incidents in those areas. So early indicators around this rollout are showing that it is supporting our patient safety strategy. I'm also going to highlight that our falls lead has reviewed all falls over the last two years, and whilst we can see that there has been an increase in falls this year, what we can note certainly is that for most of the falls recorded, again, resulting in low to no harm. So we continue to monitor our falls within the organization and putting an emphasis on falls prevention as well as staff training to support this. We discussed earlier around our learning from deaths with the focus on leader, and we've reported here on the number of cases that have gone through for leader reviews, and actually that there's been no particular actions directed to NHFT with regards to any of the leader reviews that have been conducted. I did mention and put in the chat that what we can do for the next report will be just to provide some bullet points on the learning from those leader reviews. This goes through the patient safety committee, so again, it is looked at in further detail there. I also wanted to just highlight with regards to the previous issue that we mentioned in the board around our serious incidents, concise investigations, and thematic reviews that were awaiting to be assigned an investigator. I can confirm just ahead of coming into this meeting that all our serious incidents have now been allocated a reviewer. We do have 2 concise investigations awaiting allocation of a reviewer. So with regards to this action, I can confirm that what we have put in place to manage this situation and mitigate it is working. Myself and the Chief Operating Officer are in regular contact, so we do meet regularly to look at this position and look at where we then need to ensure that allocation has been done urgently. And this then meets our requirements insofar as ensuring that we are learning in a timely manner, as well as responding to previous concern raised by the coroner around us completing the investigations in a timely manner. So we have put that in place, and we continue to review this regularly with the Chief Operating Officer. I've also put in information within this report around our internal assurance meeting and those cases that are discussed within the IAMS meetings, noting where we did have a case that was wrongly graded, and we've looked at how we can support the teams to ensure that these incidents are revisited and looked at. We also note that when some of the incidents are classified at that time, it is reported based on the information available, so we may need to then revisit to regrade that incident. So having gone through this information with the patient safety manager, assistant director for patient safety, and the director of patient safety, we are assured that the processes we have in place for reviewing incidents are robust and reflected in some cases being represented in the IAMS meetings. The last part that I'd like to direct to yourselves is with regards to the work that's being done around patient safety projects in community beds, where we've highlighted how the Innovation Fund is being used to support these projects, which is really positive work that the teams are carrying out, and just wanted to highlight this to board around that work that's been done through the support of the Innovation Fund, and to just say we are very pleased that this is now being utilized by the teams. So the last part is the ask of this board to just review the information that has been presented and to be assured that we are reporting in an open and transparent manner and that incidents are being managed and we are learning as an organization. Thank you, Chair. I'm happy to take any comments or questions.
Thank you, Linda. Anything that anyone wants to raise? Julia?
Thanks, Christian. Really briefly, just to support Linda, this level of detail gets scrutinised thoroughly through the Safety Committee, as Linda just said. And I think the level of information that comes out, particularly around the thematic reviews and the fact that we had a presentation about community nursing and intermediate care teams, and the fact that it was an independent reviewer and it took a while to get going, but actually it's incredibly in-depth. And I think there's a huge amount of assurance gained from that meeting, and this brings that to life. And I think the layer of assurance, the level of assurance is really strong from this committee. We do look at both, innovations alongside things that are challenging, and the level of scrutiny is huge.
Thank you, Julia. Thank you, Linda. I don't think there are any other comments, so we'll take the assurance that's been provided. I think helpful additional insight from Julia regarding the focus of the Patient Safety Committee, because obviously this is a huge area of priority for the organisation, and important that we continue to focus on it. So thank you. We move on to paper O. Linda, if again, can I ask you to be brief? In terms of input, because people might have questions to ask, which is important that we allow time for that. Thank you.
Thank you very much, Krishni. Again, I'll take it that this paper has been read, and just to provide the additional assurance to Trust Board that there is a monthly monitoring workforce safeguards meeting that takes place. A report then goes into the quality forum, and also in between the time that we are not meeting in Trust Board, information is then presented via this report to the Quality and Safety Committee previously, and now this is presented to the Integrated Assurance Committee. So we continue to scrutinize our workforce requirements, as this is key insofar as ensuring patient safety and the quality of delivery of our services. The things that I'd like to highlight with regards to this are that for this particular period that we're reporting, we're not reporting new workforce risks. Most of these will be risks that we have previously reported on. Just to note that as a trust, we are reporting our information internally with regards to term furlong, but we're not able to update this onto NHS Digital because of the number of units that we can report. So just to assure you that we are monitoring this information internally and feeds into all our reports. It's just not able to then be published with the rest of our information on the public platform. The new risk that has been highlighted here is with regards to advanced clinical practitioners. Just to mention that with regards to this risk, it has been discussed in detail, and there was a subsequent meeting yesterday around looking at the colleagues who have completed this course. What we are aware of is that we are flagging it as a risk, but we do have mitigations in place, because this now looks at us going back into the different areas where we have vacancies, and we look at then converting those vacancies, i.e. we would have to change our establishment, complete our EQIA processes in line with that, so that we do not lose these staff who would be valuable in filling up a lot of the gaps that we have. So just to assure that, yes, it is a risk that they're not automatically going into posts, but we do have a plan in place so that we retain and don't lose these qualified staff that we absolutely need when we look at our vacancy levels. I'm not going to go through the information that has already been highlighted through the previous workforce reports around sickness absence, vacancy information, and subsequent information that Chris Oakes will have already highlighted in the previous reports that he's mentioned. I did want to come back to highlight with regards to Level 3 safeguarding adults training, which we have reported on previously as a risk. Throughout the previous months, we have had increased training around this area. I am pleased to say that we are closest to achieving our compliance of 85%, with staff currently in training today. So the figure I had just coming into this trust board meeting this morning was we've got 56 staff that have joined the training for today. So the update of the figures of our percentage will be done and run through by our workforce analytics team. But the information that we had previously was that we needed at least 54 staff to complete the training, which are split into our substantive and bank staff to achieve 85%. However, that figure would then be dependent on the number of bank staff and substantive staff who will have attended the training. So we'll be able to report on that figure at the next trust board. But in between that, we will have reported to Integrated Assurance Committee on that. So we feel that we will be able to meet our compliance by the time that we're having our next trust board meeting. And definitely we will have achieved that before. One of the areas of concern around mandatory training was with regards to level 3 safeguarding training for our CAMS medics. So we looked into this further and were able to identify that when we're looking at the CAMS medics, really a small number of practitioners. Unfortunately, the date that the level 3 safeguarding training was being put in place was a date that clashed with 2 of our medical colleagues. Those are their non-working days, and the other 2, those were clinic days that they couldn't cancel. So we've actually arranged for specific training for our medical colleagues. So we should be reporting on an improved compliance figure for this particular group. I can confirm that with regards to our inpatient areas, where we mentioned that they did have the recent CQC visits, Marina, Shearwater, Wheatfield, who require compliance of 90% for mandatory training, are at above 90% as of today's date. So that's something that I wanted to note and mention in this report. I have covered all the areas and would ask that the trust board is assured that we are managing our workforce risks and mitigating these, having had the earlier report from our chief executive that we are with this during periods of strike. So it's huge pressures on the teams, but would like to assure the trust board that we are managing these workforce risks and we continue to deliver our services. I'm happy to take any comments or questions, Chair.
Thank you, Linda. Any comments or questions from colleagues? I think Linda's given a pretty comprehensive report there. Julie? Julie, you're on mute.
I can't do this today on Teams. Linda, that was really, really helpful, really comprehensive. Thank you. I just think one of the areas we need to continue to look at is safeguarding training, isn't it? I was just looking at the level 3 for children's. There's some work to do in that area, isn't there? And I don't know if we can do something that's level 3 adults and level 3 children's in a day session or something. Look at doing it something differently. I don't know, because obviously we've got both to do, but it's just something you and me could talk about later. But I just thought it's something we do need to look at as well.
Yeah, so I can say, Julie, that with regards to the level 3 trainings, there are set hours that we need to complete those. So that's how we've not been able to do them in one day. But absolutely take on board that we are doing some work around the children's training as well. And part of that is to increase the training sessions that we're offering. So there were more for the adult training than children's. So we're increasing those for children's. So we should be able to report on a better compliance level as well at the next trust board.
Okay, thank you. Thank you, Linda, and thank you, Julie. So we'll leave you to just satisfy yourselves you've got the right actions in place in relation to that, Linda, and look forward to receiving an update at the next board around greater compliance on some of those training areas that you seemed quite confident that we were making progress in the right direction. So thank you. We will receive and take the assurance that's been provided from that report. And then finally, we are looking at, and of course that report does get published, doesn't it? Linda, so we do need to note that that is a published report, which the board have now been cited on. So the final report in this section is the complaints, PALs and involvement report. So Linda, again, can we be fairly brief, because this might prompt some questions?
Yeah, thank you very much, Krishni. I will take it that the report has been read and also provided some additional information in the attachment that was provided. This information has gone through our complaints review committee, which we do have involvees present, as well as non-exec directors who attend the committee meetings, and we do review in-depth complaints, including having some of the complaints that we've gone through presented by the investigators for an in-depth review. Included within this report, just to tease out, is the activity levels for the complaints during Q1. And I'd like to say that we are seeing increased complexity within our complaints. And what's not reflected and captured in this report is the work that goes on behind the scenes insofar as trying to resolve complaints and PALS concerns raised, which are our local resolution processes. Such local resolution processes are not limited to senior colleagues being involved. That includes our chief exec, deputy chief exec, chief nurse, medical director, chief operating officer, actually meeting with patients, their representatives, and trying to resolve any issues that will come up. Again, that is over and above what the complaints team will be trying to do insofar as managing the complaints process itself. Wanted to also note that with regards to the complaints that are received, there is learning that is then shared across the organization, not just specific to that particular area. And this is something that continues to be highlighted through practice with our operational colleagues. We've also included here a summary of the top themes of our complaints and how those are being managed. An additional area that we've included within this complaints report is our contact information and reviewing this against our complaints PALS information. This was something requested previously just to provide further understanding around the activity levels, i.e. our contact with patients, and actually how is this being reflected through the feedback of PALS concerns and complaints. So we've provided this additional information and hope that it is useful. We've also provided an analysis of the PALS data through Q1 period. Further on within the report, provided information on our feedback. We've moved through and rolled out across to Equivia, who are our new provider. So as at the 1st of August, the feedback that we've captured has been on Equivia and with not on I Want Great Care. So this is being analyzed. There's regular meetings that we have with Equivia, which include our involvees, our operational colleagues, corporate colleagues, where we are looking at how we then increase our uptake on feedback, looking at other models, including the rollout of SMS text message, and also making it easier for patients to be able to give feedback. So this is ongoing. There's a working group that's working to address this. We've included information around the involvement work and just wanted to highlight that the newly formed Youth Advisory Board has picked up. It's absolutely thriving and very much involved in a lot of projects that are happening across the organization. The last bit that I just wanted to highlight within the report is just to share our compliments that we receive, which is something that we always want the teams to also be cited on, because people do work hard, and it's really lovely when we see this feedback coming back and we learn from it, we share it, and we also note that it's really important that where we have received this positive feedback, it's not just being contained to that particular area, but other areas, and we then look at, is there anything further that we can do insofar as improving those areas? So this is the report, Chair, and I'm happy to take any comments or questions.
Thank you, Linda. Any comments or questions again on another comprehensive report from Linda on complaints, etc.? Everyone content with the, I think there's quite a lot of information in the report itself, isn't there, which is very helpful, and completely endorse your comment, Linda, about the importance of collecting the compliments as well, because they reinforce the when we do the right things for our patients, they reinforce the difference it makes, and I think that's really powerful. So thank you. We'll receive that report and the assurance that you've provided, Linda, around the complaints and management of that in relation to patient feedback, etc. So that concludes our quality section. We move on then to governance and assurance. And there are a couple of items here, paper Q and paper R, which actually just worth saying we have discussed and reviewed in our board development activity sort of prior to it formally coming to board. And of course, the proposed amendment to the Constitution has also been through the Council of Governors, I think, Richard. So Richard, I think in fact, this is over to Chris, actually, but I don't know if Chris wants to come in or Richard is going to come in.
Thanks, Christine. I think I'm taking these next couple of reports. As you say, in the interest of time and on the basis that we've had a discussion about this before, I won't really dwell on this too much. Suffice to say, this has been a good piece of work by Peter Howie, who's been doing this piece of work behind the scenes for us. I certainly recommend that the board approves the proposed changes to the Constitution, which brings us into line with the latest changes to the legislation. The changes are helpfully set out in Appendix 1, a summary of them, that is, if people want to see what specifically has been changed. But beyond that, I'll just move to take any questions or comments, I think, Christine, in the interest of time. Thank you.
Thank you, Richard. So, yeah, the summary is in Appendix 1 of the changes. Some of them are quite technical and some of them are just factual, but I think a couple of important ones around, as we've said before, sort of repositioning or the role of associate non-executive directors was one that was important to us from a practical point of view that we wanted to make a change to. And as I say, the Council of Governors has indeed already approved this. So this is the final endorsement required to enact the changes. So I'll take it that the board is happy to approve. Great, thank you. Then similarly, Richard, the Code of Conduct.
Thanks very much, Christy. Yes, hopefully this looks familiar to board members. We had a good board workshop on this in August, and indeed this is one of the areas that the external auditors suggested that we review. So again, the changes proposed in the document appended to report are should be those that the board are familiar with. I'd certainly commend them to the board for approval, which will also then, should the board do that, conclude that particular action from our external auditors. So I think we had a really good discussion at the board workshop, and I think we've strengthened the code of conduct with these changes. So again, I'll take any comments or questions. Thank you.
Thank you. Richard, any comments or questions? Can I take it the board's happy to approve and adopt the revised code of conduct, and that will close that action, which I think is helpful. We've taken that forward. So yes, we are indeed approving that, Richard. So paper S, I think, is an update on our plans for the external developmental review. So back to you, Richard.
Thanks very much. Yes, again, briefly, the purpose of this really is to bring into the public arena the conversation that we've been having in the board workshop. As colleagues know, we're about to go out to commission our external developmental review of leadership and governance, which is a bit of a mouthful, but we're required to do this every 5 years. So we're going to be doing this very shortly. In addition to just a generic look at our compliance across all 8 key lines of inquiries within the framework, the board in particular wanted to focus on the 3 set out in paper S. So really it is just for the board to receive those 3 areas and to note then the work that the 2 governance teams, both the NHFT and the LPT governance team, will be taking forward to commission an appropriate external reviewer using a procurement process. So really one for noting, I think, really, Christian, rather than anything else. Thank you.
Yeah. Thank you, and again, subject to the board development workshop, which was important, I think. So, thank you, Richard. I think we note that, and I don't know if anyone's got any comments they want to add, but happy to take that as noted and the update received. We'll note the next steps as well, Richard, which are obviously important. So finally, we have a few reports, assurance from the Audit Committee. So I think, Melanie, you're going to provide that as Deputy Chair.
Thank you, yes. And in a repetitive phrase that we're using now, in the interest of time, we'll take the report as read and merely draw your attention to the two advised elements. One was a limited assurance report on planned and preventative maintenance. The Audit Committee noted a range of recommendations from the internal auditors in that report, all of which had been responded to very positively by the estates team. And we were greatly assured by the level of responsiveness and planned actions that were being taken and the speed with which the management team had responded and were planning to implement actions. So no concern specifically, but obviously as a limited assurance wanted to make sure you were aware of that. And the external audit I've already commented on, which is the consideration of social value as part of our external audit commentary. And the rest, I think, is self-evident. The final thing that I'd just like to draw your attention to, though, is a really, really great result in the assurance review of the Data Security and Protection Toolkit, which was substantial, a sea of green in terms of our achievement. And as our auditors pointed out, a recognised top-tier performance compared to a wider sort of peer group. So we put that in as our Celebrate Outstanding because that was a real reflection of both the level of engagement and delivery by the team, but also the wider trust in terms of our focus on this really, really important area. That's it. Thank you.
Thank you, Melanie. That's really
Saki's
positive.
now going to challenge whether, as vice chair, I've done the job properly. Come on, Saki.
I mean, a very quick question. Melanie may be able to close it off. Paul, I'm not sure whether you're at the audit committee, but the Involvi payments that's been going on, I think, for over a year, it's there as a shore. And so I just wanted to know that Linda and Richard or Paul, it's totally under control, that we're not going to have an HMRC visit over it at some point.
Well, let's just cover what the audit committee The audit committee received an update, which gave great assurance that a plan is now in place and a series of actions being taken. So there is still some risk of exposure whilst we're implementing the action plan, but it is extremely limited. The plan itself appeared to cover everything that needed to be done. And the committee took a great deal of assurance for that. There are some other limited areas of ongoing risk, as there are with other areas, and we can revisit those because I think we will circle back round and just make sure that everything is on track as we go into the December and the New Year audit committees.
Thank you. I think looks like Melanie has answered the question and Paul's put his hand down, so that's great. So it sounds like it's work in progress. There's more to do, but there is a plan around it, which is I think you're suggesting there's good assurance around. So that's a really helpful report. Thank you. Any further comments or questions on that? Okay, thank you. We then move on to the group report, the LPT and NHFT group report. David, anything you want to speak to on this?
I'll just draw out 3 key points, one of which you've already alluded to in the meeting. So we're looking at how Julia for NHFT and Faisal in LPT can support this group further, and we've made some changes with that. Also want to just be clear with everybody, we've added innovator into the joint working group priorities to reflect where that is and the importance of that. Richard and I were lucky enough, I think I'd describe it as, to be interviewed by NHS providers earlier this week who are undertaking a case study of collaborative working and want to feature NHFT and LPT group as a way of working and developing. So that was it was actually quite a rewarding experience to be interviewed, because it reminds you how much you have done as people are talking to you, because it kind of becomes normal. It's what we do around here, and actually having a conversation with somebody where you realise you're not the same as everybody else is really helpful. And then the last thing I was going to touch on was just to say, have completed an effectiveness review, and that's been really helpful. All the areas are of high assurance, so I wasn't going to go through things any further.
Thank you, David. And just to add, really, we just wanted the board support for the addition of the 9th work stream, because but it felt important that we do, because it is a joint area of work. So it's just going to be formally included within that, because obviously the innovators scheme, the provider collaborative innovation scheme that we secured a place on, we did so jointly as a group, and wanted to make sure that then, because that's quite an important piece of work for us collectively, that was reflected in the joint priorities. So we would like the board's support for that. And as David said, just really to confirm that there are some, it was a very helpful annual effectiveness review. We will take forward the priorities that have been highlighted there. And Julia and Faisal are going to share the sharing of this, which we thought was a helpful sort of way of making sure, you know, we were working together, but the needs of both organisations were very clearly represented and being facilitated through the deputies taking that joint ownership of the committees in common. So the board is asked to note that and just really support that change to the joint strategic priorities, which I think we've highlighted there. Richard, anything you want to add?
No questions.
No.
Thank you.
All covered. Great. Thank you. So everyone happy with that? Good. Finally, then we have the Nominations Remuneration Committee annual report. So Chris, over to you on this.
Yeah, this is the annual report we're required to present to the board. It's listed out all the actions that the Remuneration Committee has undertaken through the year, and board are asked to just confirm it's assured and that the NRC will continue with its role for next year, or for this year as it will.
Thank you, Chris. I don't know if there's anything that the colleagues want to question or pull out of the report, but just to particularly highlight, because I think it's important, that we say in public that we have in fact gone through the fit and proper persons test, as is under our existing policy, as opposed to the new policy that will come into effect under the CARC changes. And we undertook those that review for executive directors under the guise of the Nominations Remuneration Committee. For non-executive directors, we did that with the Council of Governors Nominations Remuneration Committee. Assurance around that was reported to the Public Council of Governors that took place in September, and therefore assurance around this is being reported in the Public Board, so that we are undertaking our duty on that transparently. So I just thought that was important to note, because that is a very important action that we take every year. And you know, we will obviously be taking account of CARC, and Richard, myself and Chris have already had a conversation about that, and how we take forward the strengthened fit and proper persons test and regulations over the coming months. And I think that's all I wanted to say on that. So if there are no further questions or comments on that, it is just a point of assurance for the board around the work that the Nominations and Remuneration Committee are undertaking. Thank you. So we get to the final point in the agenda, which is items for information. NHFT's board declarations of interest. I was conscious that I should declare. I didn't think it was particularly relevant through to anything that was being discussed, but clearly that needs to be updated to reflect my chair role at LPT. So I did want to just note that. I had mentioned it earlier in the meeting, obviously, that I've started taking on that responsibility from the beginning of the month, but important that the declaration of interest includes that. And indeed, I would just encourage everyone to think very carefully about any interests that need to be recorded. I think it's really important we remind colleagues that this is not a register of conflicts of interest, it's a declaration of interests. And transparency is where I would generally recommend people go around interest, so that we're really clear that we can manage any potential conflicts. So if there are any updates, please submit them. Beyond that, I think we're at any other business. So I don't think I'm expecting any other business, Angela, anything that was urgent. Okay. So just getting to review of board performance, I think the only thing I wanted to highlight is, apart from the fact that we are a little bit ahead of time now, having sped up appropriately. So thank you everyone for playing their part in doing that. I did just want to take the opportunity to say, what do we as a board think it would be helpful to include in our assurance topic for governors at the next council? I was conscious as we were going through that the two alerts are actually the same as previously. And I'm not sure that revisiting that immediately is helpful, because I think we want to take perhaps some more action and take forward our sort of action plans around those before reporting them back to governors. So I don't know if colleagues had any thoughts about anything that we would want to brief the governors on, but if you have, this is an opportunity just to note that. There might be some advice areas that would be quite useful to think about sharing with governors. Robin?
Just going to say perhaps the partnership working one, particularly in relation to the voluntary sector, since the governors keep raising it. So I think that would be an appropriate thing to feedback to them, the very good work that's going on, to develop greater kind of strategic thinking about how we do so.
Okay, thank you, Robin. Julia?
Excuse me, perhaps the WRES 3 very substantial reports we received. There's some really good information in there, and we received a level of assurance on that, but that might be a detail to go through.
Okay, thank you. Well, we'll note those and we'll sort of reflect further, but just thought it would be helpful to take that opportunity. And any other points that people want to make in terms of how we've managed our business today, and any reflections anyone would like to share? Everyone happy then? I'll take it that everyone's content that we've covered the business appropriately, and indeed, if I stop talking, we might actually finish a bit before time, which I guess is what everyone's waiting for. So I'll take it that you've got nothing else to add. So thank you, everybody. I'll bring the meeting to a close. Our next meeting is the 30th of November. And we obviously have our private meeting starting, I think, in half an hour. Richard, is it? So 1:30. So we'll see colleagues there for that meeting. But otherwise, thank you everyone for contributions, and I'll see you shortly. Thanks.
Thanks all.
Thank you. Bye.